seats and get on with the conference. All right, it appears that the music has toned down, which is a clear sign that it is time for me to begin. Truly a nudge more than like a loud announcement. When we talk about kids, like a lot of the times I hear that children are basically very small adults, but you know, in a lot of cases that doesn't really apply. It applies to, for example, negotiations. Sometimes children need a different approach, and the same thing also applies to how we apply medicine to them. For example, we at the same time want to protect them and create these crazy innovations, but there are so many barriers. We're trying to protect them, but by trying to protect them, we're also stymiating this potential for innovation. And it creates this negative feedback loop. But over here, we have assembled, and for the fourth time, this is the fourth installment of the Pediatric Innovation Day. The previous two ones were in Barcelona, and the first two ones were in Barcelona, and the previous one in Warsaw. Now we're here in Riga to also better understand how we can help the adults who help the kids. Help these adults, like a very, like a stumbling kind of sentence. But that's me. My name is Kasper Saglidis. I am a developer for Neural DSP, and I also own a business, Tandems, where I help involve people, citizens, into decision-making, urban planning, and design. Today, we will be speaking until around 4-5 p.m., a lot of different talks, and we have this huge gargantuan task of putting all this knowledge into about 8 hours of time. But we will manage. We have done a lot so far, and we will do more. For the speakers, just a little housekeeping. So over there's some coffee, and we have a super tight schedule. I mentioned the 8 hours, so as soon as the time is up, I'll be imposingly getting up on stage and standing next to you until you realize that your time is up, and it will be time for you to wrap up. That's one thing, and I think, without further ado, I think we can start. So first, I'd like to give the opening speech. I'll give the floor to Fatima Nunez, the Deputy Director of Research, Innovation and Knowledge Management at Sant Joan de Déu Barcelona Children's Hospital.
Okay. So, thank you, Kasper. I know we're on a tight schedule, so I did write a speech, so it's just 5 minutes, okay? So I won't take you much of your time. And I know this is the least interesting part of the day, so I'll be trying to make it agile. So, good morning, everyone, and welcome to Pediatric Innovation Day 2024. It is truly an honor to stand before such a vibrant group of professionals, innovators, and passionate minds dedicated to reshaping the future of pediatric health. Here we are, gathered in the beautiful city of Riga, at the forefront of a movement that promises to redefine how we think about child health. This year's theme, Advancing the Frontiers, Innovations for a Healthier Future, is not just a title, it is a call to action. A call that invites each of us to imagine, design, and deliver breakthroughs that will impact generations to come. Let's take a moment to reflect on where we stand today. Pediatric healthcare has made significant leaps over the last few decades. From groundbreaking treatments for rare genetic disorders to advancements in neonatal care that have saved countless lives. But while we celebrate these achievements, the future of pediatric health demands more. More creativity, more collaboration, and more investment, and above all, more innovation, because the future looks promising, but still lags behind in terms of solutions into the market. What excites me the most about today is that we have a gathering of professionals from all ages and backgrounds from all over Europe, and that many of you are in the earliest stages of your careers. Young professionals with fresh perspectives, unburdened by the constraints of the past. You are the generation that will accelerate change in pediatric healthcare. You have access to tools and technologies we couldn't even dream of a decade ago. Whether it's AI, genomics, personalized medicine, or revolutionary surgical techniques, the possibilities ahead of us are vast. Our mission today is not just to talk about these possibilities, but to turn them into realities. Let's think about the power of innovation, which isn't limited to the labs or high-tech centers. It is found in how we design systems that are more equitable, in finding new ways to deliver care to underdeserved communities, and in making treatments more accessible and effective for every child, everywhere. Innovation also thrives in multidisciplinary collaboration. I would add, it thrives in intergenerational collaboration that brings together different perspectives, interconnected knowledge, and complementary conceptions of life. No one person, no single institution can solve the complex challenges of pediatric health alone. That's why today is so important. It's a chance for us to come together, share our ideas, and build networks that will help us transform the landscape of child health. The problems we are solving are not just technological. They are human, and they require empathy, creativity, and a deep commitment to improving lives. And that is exactly what we have begun with i4Kids Europe, and what we must continue to build upon. Through this growing network, we are bringing together all key stakeholders with a common purpose of transforming pediatric care for the better. I believe we are on the cusp of a revolution in pediatric healthcare. Imagine a world where every child has access to precision medicine, where chronic diseases are managed with data-driven insights before they even show symptoms, and where we can intervene earlier than ever to prevent illnesses before they take hold. This is the future we are working toward, and it is within our reach. Today, let's not just look at what's possible, let's look at what we can make possible. Let's be bold in our thinking, fearless in our approach, and relentless in our pursuit of solutions that can change the trajectory of children's health globally. I'm confident that the next big idea, the next breakthrough that will transform pediatric care could come from one of you sitting here today. So as we dive into the discussions, workshops, and networking sessions, I challenge you to push boundaries, ask tough questions, and inspire each other. Because the future of pediatric innovation is bright, and together we are going to light the way for healthier generations to come. Thank you, and let's make today unforgettable. Thank you.
Someone who is at the forefront of pediatric innovation is the CEO of the Children's Hospital of Latvia, Valds Ābols. It is your turn to give an opening speech from the home team. And there he is.
A 2-year-old girl named Elena was brought to emergency department by her worried mother. For the past 3 days, Elena has been battling with seemingly severe cold or flu. He had a diarrhea. She developed a high fever, so she barely responded to any medication. She had a cough. Her mother explains that Elena had become more and more tired over the last 24 hours and barely moved from her bed all day. She refused to drink, and any attempt to get her to drink even a small amount of water has been unsuccessful. So Elena looked weak, she looked pale. Her mother was worried and carried her to the emergency room. And it was clear also to the nurse that Elena's condition was quite severe. She was distressed, her skin was dry to touch, and she has lost a lot of energy and even to cry. And Elena is just one of many kids taken to the emergency room with similar conditions, being dehydrated, and usually also with imbalance of electrolytes. So standard of care would be in this case to recommend to replace the electrolytes, to have a specific drink, or at the end of the day use intravenous access. But in case of Elena, very similar to many other children, that option of having electrolyte drink is not the accepted one. She had a very strong taste preferences and not for electrolyte drinks. But when the same content is proposed to her as part of the ice cream, that makes all of the difference. And that's an innovation. So thanks to the small and persistent team in our children's hospital, working together, finding the ways how to make an ice cream out of the electrolytes makes a difference. And that's how we can provide the care, unseeming care to the kids when they come to the hospital, thanks to those small innovations. Yesterday, some of you were visiting our hospital, and I mentioned that we are celebrating 125 years next week. And it took a lot of effort to get to those 125 years. I think the ultimate and the biggest question is what will it take to get to the next 125? And I think the answers seem pretty obvious. We cannot stand on the same place. We need to move forward. We need research, we need innovations, we need technologies, and that's all true. And that's why we as a children's hospital have committed to the ambitious project to develop the Healthcare Advancement Center, and I'm confident it will be a success story. But it takes more than that. Whatever we will do in technologies, I think in a few decades, it will still be, it already will be outdated. But there are few things which will never be outdated. And these are when we focus on the needs of the patients, when we focus on the needs of the children and families, and only these, like this focus can take us to the 125 years forward. So that also serves as a guiding light, as a true north for all of the innovations, which makes added value. And I hope this day and also any activities after this day will serve as the kind of inspiration to keep focusing on the needs of the patient, to keep focusing on the needs of the family, because that will be the true innovation. Thanks.
From a big picture to an even bigger picture, let's have a representative from the government. Artyoms Urshulskis, Parliamentary Secretary of Ministry of Health.
Good morning, everyone, and welcome to Riga. First of all, big thanks to Fatima for reading for the paper. I also have a paper. It's much easier after you to do that. It's actually quite strange, actually, to stand here today, this morning, because imagine yesterday I had a unique opportunity to participate in military drill. I was shooting from the M16. I was throwing hand grenade with my broken hand. I was sitting in the trenches, in the sand, and all the helicopters were around my head, and all that crazy wind was going inside my eyes, my nose, my throat, everywhere. I'm still very sandy, and I was just, laying there and thinking that I'm just a piece of sand. I'm like nobody, because when the war is there, one person can change nothing. And now I'm speaking here about innovation. It's very strange, really strange. But indeed, it is a very important part in what we should do in the future as a policymakers, as implementers, as a whole society. We really need to find a way how we can integrate innovation in our healthcare system. And speaking of our ideas, our experts in pediatry, I think they are enormously good. Our children clinic University Hospital is an amazing example how smart investments in human resource, smart investments in training, smart investments in facilities, and also in technology can bring us excellency. Actually, we would like to see that excellency in every single hospital in Latvia, but we're working on that, not so easy. But in terms of childcare, we are really there. And I'm very lucky that actually not only Ministry of Health, but also our counterparts in other places and other ministries in Latvia who actually give us money, Ministry of Finance, they actually finally understand that it's not a spending anymore when you invest in kids, it's an investment. It took us many years actually to convince them to think like that. But right now we are there and we can find that money, but probably the biggest challenge is how we integrate the technology in modern life. What else is here? I don't know. Artificial intelligence, very important thing. We are thinking of that and how we can make it real in somewhere in our healthcare system, because that is definitely a driver to big change. That is definitely a huge step forward and totally different era and how we can approach the modern technologies. But I also think that it could be quite actually dangerous, because when artificial intelligence grows, it may become even smarter, which is good, but more independent, which sometimes is not very good. We will still need very experienced and very knowledgeable doctors to actually analyze what artificial intelligence will bring us. But if we can find a way, and I believe that you should be the most capable people to find that way, how we can integrate one system into another and actually bond them with the professionals working in the field, that should be the thing. So I hope that you'll have really nice event. I hope that you will make a lot of new friends, a lot of new connections. This is actually why we go to the events. And probably also find some completely new solutions or develop the existing ones. I really hope that you will do that. Work together, make new friendships, and just let's make this world better together. Thank you. Have a nice day.
So now let's get to the meat and bones of the i4Kids, the Pediatric Innovation Day. So right now there is a presentation, a keynote about the challenges and opportunities and in pediatric innovation. And this is part of the i4Kids developed under it. So this is going to be a speech, a keynote by Charlotte Bertod, Project Officer of EIT Health, Spain.
Thank you. I don't know if I have something to change the slides.
Yes, you do have a clicker. Here you go. It is on and it works.
Perfect. Thank you. So last week, I was watching a documentary about the microbiota. And do you know how it starts? With babies. Because children's health matters so much that it will impact our guts, but our health in general during all adult life, with a long-term impact. And that's why children's health is so crucial for the future of healthcare. And I guess that's also why we are being here today, to all contribute to push pediatric innovation forward. And this is also one of the missions of i4Kids Europe, to really increase the knowledge and visibility of pediatric innovation and really to boost its competitiveness. And we are doing that with all the partners that are here and that are also here in the room today. So when we started the project, we knew that there were two major problems to pediatric innovation. The first one was a clear lack of European focus on pediatrics, with health innovation still tending to focus on adults. And here you can see Francesca. She's Italian, she's 3 years old, and she's suffering from a cardiac disease. But she will be treated with oversized devices that is not adapted to her size or for children. So that's the first problem, because it needs to be adapted for her needs by the clinician. On top of that, the second issue to this lack of solution is the fragmentation of the ecosystem in Europe. So Francesca from Italy won't receive the same care as in Finland, for example, because they are suffering from this lack of this more pronounced lack of pediatric innovation that is existing in these countries. And that's why European Pediatric Innovation Network is needed, and that's what we are doing since almost 2 years in this project, to reduce barriers and create synergy for innovation in pediatrics. So my name is Charlotte. I'm a project officer at EIT Health, and I'm really proud to be part of this i4Kids project. Over the summer, we have been working hard on this white paper. So this white paper has the goal to shape the future of pediatrics, to more or less to have a vision of where we could be in 5 years, in 10 years in pediatrics, and try to bring all the improvements that we can have for that. Today I want to share with you the most interesting pieces of this white paper, going from the barriers that are existing to success cases and also recommendations that could be applicable in Europe. So we put all of that together in a roadmap, having all the opportunities that child health can offer, and it's a real call for action for implementation to this more effective pediatric innovation in all Europe. So, what's the current state of pediatrics in Europe? So children represent 25% of the population, but they are receiving less than 1.5% of venture capital in healthcare. And this number is dramatically low. And it's also particularly reflected in the access to medical devices. So as we can see, there are way fewer technology for children than for adults. And children suffer from this limited access to medical devices, meaning that their specialists don't have access to the tools they need to address the unique needs that have children. And here you can see, in the US, there are around 60 medical devices that have been approved in 2021, here with the subpopulation for the unique needs of children. And do you know what is this number in Europe? Someone has an idea? Well, me neither, because there is absolutely no data about what is existing in Europe. While the FDA has been reporting the number of medical products that have entered in the market, in the EU we have absolutely no data in what happened in the last 10 years. So it's a huge problem. And on top of that, the average delay in the approval of medical devices in pediatrics compared to adults is of 10 years. It's huge. So isn't that so realistic that a 5-year-old needs to wait 10 years when the needs at this age are evolving so fast? She will pretty be much an adult at this time. So I think that's why decision maker should think like, I'm late for a very important date, because pediatrics will really benefit to reduce this time frame and having one closer to the adult. So that being said, pediatric innovation is lagging in Europe, that's what we can see, but there are some challenges ahead, but particularly large potential for opportunities, and specifically in this moderate and emerging regions that could benefit from all the recommendations that we will see now. So I don't know if I can take that. No, I don't think so. Okay, I will stay like that. Ooh. You can, yes? It will be easier to see the slides. Thank you a lot. Perfect. So last year, we have been presenting these reports about barriers that are existing in pediatric innovation. We based it on around 130 questionnaires that we completed with 25 in-depth interviews with experts. And with that, we understand better these 8 main barriers that are hindering pediatric innovation. With that, we had some important results. The first one was to show a broad consensus over the barriers that exist in pediatric innovation, with the first one that is really clear and is financial, obviously. The second one was regulatory and reimbursement. But more than that, we saw that there were different prioritization depending on high innovation region or low emerging innovation region. In high innovation region, the major issue was on regulatory and commercial barriers. But for emerging region, there was human capital, infrastructure, and cultural and incentives that was the most important, that they ranked as really high. So we saw that the ecosystem was not operating at its maximum capacity with that, and we reached out to key experts. With that, we moved from 8 barriers to 4 working groups with a lot of stakeholders. Some of you might have participated to these working groups. And today we really want to present, to display all these results that we have. So I've been compiling the main barriers, success cases, and recommendations that are needed. And we will give you an highlight only of some points. The rest will be available in the full white paper that will be published later. And yes, it will be like that, because no one like complete spoiler, right? So, the first main barrier, let's jump into it, financial. So public funding in the US allocated to pediatric research is only of 9% when it's 25% of the population. And we can see that we have the same problem in the European Union. We have a problem with the funding system, particularly with the public funding, where we are lacking public funding, and this year where there were only 2 European calls on that. We also see that there were critically low private funding, but more than that, that was a shift of mindset towards pediatric innovation that is needed, because pediatric innovation suffered from a constant comparison with adult market that always appear as small with low return on investment. And project will benefit from shifting to being assessed on a pure economic point of view to also include a social impact measurement. If not, pediatric innovation will always appear as the black sheep. We have a success case on that for the funding system that you might know. It's a Pediatric Device Consortium grant program. It's a funding program by the FDA that is existing since 2009. It's a support program to develop and commercialize medical devices for children and really try to mitigate this underdevelopment that is existing and underinvestment due to the smaller market. And how does it work? So it created 5 consortiums that receive critical funding of 1.5 billion euros, and they receive logistical expert support to help startups to develop new solutions. So our recommendation on that will be like to implement a European PDC, to have the same idea and create consortium all over Europe that will have this funding and could develop new solutions. And for the shift of mindset, we will also recommend to launch a social bond in pediatrics, as it can happen in the UK, to address the social and met needs that is specific to pediatrics. And finally, there is also a lack of awareness on pediatric projects. Do you have in mind some 5 successful projects in pediatrics? Maybe no, because there is a clear lack of visibility on that. And that's why we recommend to create a collaborative platform with all pediatric opportunity that could include the most relevant stakeholders, investors, public calls, and so on. Everything on the same place to have a clear vision on that. So, our second point is regulatory. This one came with many challenges during the working group, and there were more than 100 recommendations of improvement. So a first good sign is that clinical trials in pediatrics has increased by 50% in the last years, and now represent 12% of clinical research. I will only highlight some points. So usually most research is focused on adults, which reduce solution for children. And we can see that particularly with that there are some incentive existing for development of new medical devices, new medical products in general. But waivers are existing that are providing space for industry to avoid pediatric development. So it means that, for example, in oncology, if you have a pancreatic cancer, it doesn't apply in children, so it's not a problem. But for other oncology cancer, the company can do to not have a development of this cancer for children. So we recommend to revise this pediatric regulation, and when a solution is useful for a pediatric disease, then no waiver could be possible. And the second point is, as we know, that there is smaller sample size in children, so it's more difficult to recruit children on some illness because there are less. And on that, there is this success case that is really interesting on DFA breakthrough therapy designation. And it's a kind of fast track to review faster a solution that is really needed. And for this promising treatment, to have a fast track and go faster to the market. And that's what we recommend in EU to have that and really accelerate this time. So our third barrier, commercial reimbursement and adoption. So this one is really critical for go-to-market action. And on adoption, we can see that there are only 20% of medical devices approved in children that are made available for use in pediatrics. So the first one, maybe the most important one, is the commercial hurdles. So there is a clear data gap that harms the commercial interest. So, for example, when a medicine or a device is used off-label, there is no evidence to validate if it's a benefit or if it's harm the practice on children's health. And off-label application, as it is usually not so ethically accepted, are not studied. But the issue is that the pharma industry has no evidence of a commercial interest or a commercial need. It just appears that the population has few needs, and therefore it's a less attractive market for them. So the recommendation will be to build a European biodesign program based on the Stanford biodesign that is existing in the US, and also to organize a pediatric European open innovation challenge that will really put pediatrics as a more attractive sector. We also have the issue that in some countries, for the reimbursement, it can be really lower than adults, and it doesn't reflect the high development cost that it can represent for a company. For that, we have a lot of success cases, but mainly what we recommend is to generate incentive to reward companies who invest in pediatric innovation. And on adoption, I know there will be a roundtable on that today, so I will just skip this one and let them the work for later. And last but not least, human and infrastructural resources. Found that the main point is that innovation culture in hospitals. Usually hospitals lack a real innovation department, and particularly in pediatrics. So we recommend to really set up in whole children hospital innovation departments. And when it's not possible, a possibility will be to implement incentive system with dedicated hours for innovation and motivational system. So a proposal that we had, for example, in the working group was to reward innovation with fundings that could be injected directly in the project proposed by healthcare, but by the healthcare provider within hospital. So they will have the money for their project and could implement it there. And training, always really important. So staff is usually not trained, don't have this innovation mindset, and are lacking these commercial-oriented skills because they don't have the training for that. And on that, we have the i4Kids Europe training capsules. Maybe some of you know it. It's a monthly training capsule. It's online, it's free, it's recorded. So I really encourage you to look at it, and it's focused on all kinds of stakeholders in pediatrics. And finally, this one also really important and came into a lot of working groups, that medical schools really need to integrate innovation classes to bridge innovation and care. So that being said, with this white paper, we saw like the current state of pediatric challenges and success cases. And with all of that, we have built this strategic roadmap that consider these four main barriers and organize them on top of that on what need urgent action and what needs profound transformations that might need some time. These key recommendations are a really call for action for decision makers and are really thought as the foundation to have a more effective pediatric innovation. So if you're not convinced, maybe a last one, why pediatrics is an interesting investment. I will tell you the myths and the realities that might exist. So the first one might think that the market is too small, but in reality there is a growing market demand with rising demand for tailored treatment for children. Some people might think, okay, a regulatory path is long and it's risky. In fact, there are a lot of regulatory incentives, such as extending market exclusivity for pediatric products, or also the orphan devices that just came during the summer, this regulation. The third one is children are not sick, but unfortunately, in reality, there are a huge unmet needs with more than 6,000 rare diseases, 7 million autism spectrum. So there are a lot of opportunity for breakthrough and market leadership with a long-term impact. And finally, maybe you think there is no good project success cases, you don't know them. But with the platforms that we mentioned before, it won't happen. And Particularly, there is really good news that we have more than 150 startups in Europe that are focused on pediatric innovation. And on top of that, pediatric is benefiting from the involvement of final users that are really active. And with that, we really want to count on them and on all of you today to really push the white paper, to really support it, because that's why we need if we want to change pediatric innovation. And that's what I wanted to say. If you want to arrive fast, go alone. If you want to go far, go together. So I think all together we can really help to push it and change, to shape pediatric innovation in the following years. So stay tuned because the white paper will be available in November. And I also want to take advantage to say a big thank you to all the experts and all the partners that participate in the white paper, because I think it's a really great work and we hope to see the result really soon in this month. Thank you a lot.
All right, thanks to Charlotte. On a side note, if you ever want to talk to one of the speakers and get more inside scoop about what they're saying, there's going to be a coffee break and a networking event afterwards. So try to remember what they look like and try to remember all of the questions that you had while they were speaking. And this time the challenge is going to be 4 times as large. There are going to be 4 speakers at the same time. So this is going to be a panel. And the panel consists of mostly C-level executives, I'm going to understand. By the way, these chairs are specially made for this event. It is by Igloo, and they usually make these, easy to clean things for kids, like Giga Legos, if you may. And now they've made these chairs specifically for us, which is a great big thanks to them. But yeah, when talking about innovations, and during this event, we're going to go from the most abstract to the most practical. This one is going to be also more about strategy. So a panel by representatives, 3 representatives from the European Children's Hospital Organization. And the 3 are, first of all, Marlene Fischer, the Rikshospitalet's Director of Research and Innovation. Marlene? That's you, okay. We have Anne Quinn, Head of Innovation of Children's Health Ireland. We have the aforementioned Valts Abuels, CEO of Children's Hospital of Latvia. And this discussion is going to be moderated by Anda Asare, journalist of Labs of Latvia and co-founder of Friday LB.
Works wonderful. Wonderful. Happy to see you all here. We have a very, very serious discussion. But first of all, I would like to ask very serious, very easy question. So what exactly are innovations if we are talking about innovations in pediatric, in children's hospital? Anne, let's start with you. So how would you say, what is innovations if you are thinking about them in this context? Yes, here you are.
Thank you.
Hi everyone, it's really great to be here today. I think it's an easy question, but it's also a very difficult question because I think in the time I've been working as Head of Innovation in Children's Health Ireland, one thing I've learned is that everybody approaches the topic of innovations very differently. We all have the same end goal, but how we approach it is all different, and I think that's great. For us, innovation, when you think about innovation, you think about technology, you think about devices, you might be thinking about AI and different advances in precision medicine and things like that. And they're all really important outputs of innovation, but we also are very interested in looking at innovation in terms of how we deliver care. So how can we innovate in the processes of delivering care? And also, how can we innovate around the experience of care? So how can we think differently about the experience of care for children and families that come into our hospitals? And then they're all very important products, but we're also really interested in thinking about innovation practice. Okay, so the process of getting to those products is as important for us as the actual products themselves. So how can we encourage our organization to be more innovative in the way it exists? So how can we influence the culture of our organization? How can we encourage staff-led innovation? How can we remove barriers for staff who are interested in innovating? How can we think differently about our culture, our structures, and our partnerships? So that's something that we're very keen to do.
Wonderful answer. Thank you so much. Melanie, how would you say? What would you add if you are thinking about innovations?
Well, for me, first and foremost, innovation is bringing an idea into use. So that is a very broad definition. That could be, as Anne said, anything from a building to organization to a device. An example, of course, I would like to highlight in this forum is the building of the Mary Elizabeth Hospital for Children in Copenhagen, where we took the whole process of doing this was from an innovation perspective. So starting with the children and the family and the end users and looking into the hospital from their perspective. What is needed for this hospital stay to be a good experience? How can we integrate play into the building, into the care systems, into the wayfinding, into the way the staff is trained? So really taking, I would say, innovation to a whole new level, starting with that and integrating it into the organization. That have been a very interesting, a very fruitful experience, which I think, I hope that we can actually translate into the adult system as well, where innovation currently at least is something that is happening in small areas, small pockets of the organizations, where I think we need to bring the innovative mindset much, much closer to the clinical staff, to the clinical routines. So having an innovation department is all very good and a good place to start, but it needs to be integrated really truly into the entire organization. I guess that what I would say for now about that.
Thank you. Waltz, I really loved your example about ice cream with electrolytes. What else can you add? What else you can share on if we are talking about innovations in hospital of children?
I think that spectrum is very, very broad, and obviously everything what you said already, and it seems that there are so many innovations already available. But when we think about those key categories, we can realize that there are so much opportunities actually lie ahead. If we talk about, you mentioned, experience or enhancing this experience of the patient or the family, and it's very, very broad spectrum of opportunities. We can take, the one thing is treatment process itself, but there are a lot more. It's about the integration of the different care elements before the hospital, after the hospital, etc., etc. So, it's the opportunities are basically, you cannot really name everything what's possible to be innovated, in terms of that. The second is the block is the personalization, and we talk about precision medicine, and more we talk about precision diagnostics and in the scope of really prevention and early detection. So opportunities are immense there. So the third thing is, which we constantly focus in a hospital is, everybody knows the shortages of the staff, the smart working requirements, being it nurses, being it physicians, being it mental health specialists. So you need to find the solutions. So anything really which helps the physicians or any medics or anybody in a hospital work smarter, do less, spend more time with the patients rather than do a little bit more. It serves as innovation. And finally, obviously, is a decision. So we are still making so many decisions on a pooled level, on an aggregated level. And I think those data which are already available in the hospitals if used smartly, they can provide much more precise decisions, much more like personalized decisions. So basically allowing us to make better and more informed decisions. So that would be innovation as well for me. And from the hospital perspective, I think the one aspect which actually I enjoyed very much reading this Nassim Taleb's book, this Anti-Fragility. And I think that we think about the hospitals as robust and resilient, like structures or organizations. But that concept of anti-fragility is something which we probably sometimes lack, and meaning that those small, like how to say, distractions or misses or whatever it is, or fails, don't really destroy us as an organization, but rather there is a mechanism how we grow, how we become stronger from that innovation. And I think if that innovation process is present in the organization, that's kind of adds to that anti-fragility of the hospital. So yeah.
Okay, you have a mic at your hand, so you will be next to answer. So now we know what is innovations in hospitals. How would you say, if you are looking in the past decade, how the concept of innovation in the children's hospital has changed?
How it has changed? Well, if we look towards the last decade, so there have been a lot of the things happening.
I want to hear it.
Yeah, well, I mean, everybody is aware about the advancements we have in a therapy, starting, I don't know, gene therapies and, well, telemedicine, artificial intelligence, like very specific things like in neonatal care, so we have non-invasive ventilations, etc., etc. So there are many things which happened already and which will continue to happen. So, but what is important is that we focus not only to those high-tech things, and I think that's by this design thinking or by design approach, we learn to see other linking elements, because we can have some very high-tech solution, but it doesn't really perform because something else is missing, some small thing is missing. So you can have like a, well, prepared for like manipulation in a visit with a new device, etc., etc., doesn't help if the patient doesn't appear to that visit. And there are some probably other solutions which need to be in place, how to facilitate that. You identify the patient who might not come to the visit. You do something that to like make it more likely that he will come, probably engage some other service which will take to the visit. So, and these still count as innovation, and this is innovation of the workflow, and this still will be relevant also for the future. So,
and I want to hear your addings.
Yes, I agree with everything that Volta said there, and I think one key thing is we wouldn't probably be sitting on the stage here 10 years ago talking about pediatric innovation.
Sure.
So it's amazing to see the increase in awareness around and the growing network, and I think, you know, the work that Life for Kids are doing and the European Children's Hospital Organisation and bringing innovation expertise across Europe together is really fantastic and has to be commended. And, you know, I think the other thing that we're seeing a lot and we're trying to do as part of our remit is the introduction of things like, I've also mentioned design thinking. We're looking at how to bring design thinking into our organisation as a way of thinking and a way of approaching challenging problems. So we're using it as a methodology that we can use to solve difficult challenges that we're facing, whether it's at a team level, an organisational level, or a system level. The system is much harder, but definitely at a team and an organisational level, we're looking to see how we can start off from a place of where we're trying to understand the problem and really empathise around that, and then move through to coming up with a solution that we can test and implement. So we're running design thinking programs for healthcare staff and different levels as an individual in a team-based program, and we're finding that it's really helpful from a number of different perspectives because it gives people a bit of a framework and a methodology around thinking differently about the challenges they're facing. And it's also, I suppose, really putting the focus back where it needs to be, which is the person at the centre of the problem. So whether that's the child, a young person, family member, or a staff member who are equally valid users of healthcare.
Melanie, what are your thoughts about last decade? What has changed the most?
Well, I have been in my position for 2 months, but I have been in the area of medicine for 2 decades. And I was just looking back at the vision paper for the Mary Elizabeth Hospital, which was actually written 10 years ago, a decade ago. And I would say they were quite forward-looking, with a huge focus on a holistic approach to the patient and thoughts about home care and home diagnosis. But what I think we have seen is that the development in, for example, home care, home diagnosis, home treatment, outpatient treatment have been more rapid than we actually thought. So we are now standing with a completely different care system in a way around our pediatric patients. So we need to change. This influences the way we train our nurses, we train our doctors, we train the staff, but also how we train the families to be a part of the system where quite a lot of responsibilities and of the work is actually put on their shoulders. And we need to be very aware on how we can make them ready to take on this task. I think most people would like to do it because they want to stay at home, but they need to feel safe and need to feel supported. So that is one area where I think innovation in education and organization is crucial. Then one thing I have experienced talking with patients is that the improvement in medical care, precision medicine, the use of AI, they kind of take that for granted. So that is what we do in our back office, so to say. But the way we deliver it is really, really crucial to them. So this more holistic approach to the family and to the children, I think, again, is really, really important.
How open are families to be partners of doctors?
In my experience, very open. I mean, no one really wants to stay at the hospital if there are any other way of doing it. So, but we need to be very aware on the stress we put on the families if you want to engage them in the treatment. But if we educate them sufficiently and if there's always staff available to contact if they get worried and if they know they can always get into the hospital, they're quite ready to do that. Of course, this points towards equality in care. So we need to be very aware that the resources in different families might differ. So one size doesn't fit all.
No, it doesn't. Let's talk about strategy and innovation as a strategy of part of the hospital strategy. How would you say how important it is that this idea about we need innovation comes from the hospital's heart?
Well, obviously, I think that's really important. And if I look across the Danish innovation system, there have been a lot of focus on the individual innovator, the individual doctor, the individual nurse with a good idea. How could we support that entrepreneurship? How could we get that into a medical device, for example? Where I think we need to focus now is on the organizations, as you also said, to make the organization ready to accept new innovations, new ideas, ready to implement them. And that means that we need to educate our leaders on all levels in innovation and how to integrate innovation in the clinical care so that we become a more agile organization, really, to withstand the pressure that we all under, and act accordingly, rapidly and swift.
And what kind of role hospital executives have in this process?
Well, I think, of course, strategy is one thing, defining what is the strategy, but also to put, of course, resources in the way that can support innovation, but also a leadership focus and a slight leadership pressure on the organization.
Slight one.
A slight one, just a friendly hand in the back, of course. But I really think it's someone who keeps on talking about it, keeps on highlighting the success stories, the examples, and have a look for where are the barriers, what can we do to bring down these barriers. And another thing is also, do we have the staff we need for the future healthcare system? Do we need to integrate more engineers, for example, or is it the way? Are we ready for the future, so to say? Yeah.
And next question to you. I would like to ask you how to make these right arguments for the hospital's highest level executives on why innovations are needed, why they are needed in the strategy of the hospital and its development in the future.
Yeah, I think most executives would see the need for innovation and would talk about innovation as being important. And I think then it's really about how you support innovation within your organization. And I think Volz has referred to this as well, but how do you make sure that there's structures in place? How do you make sure that there's a team that's supporting that? So I think, we're very, I suppose traditionally in healthcare we fund in research all the time, but we're not really in the space of funding supports for innovation. So I think if we can get it right in terms of innovation, not only will we have better solutions, more human-centered solutions, we'll have more sustainable solutions that people will want to use and engage with over time. And I think it's just an investment. It's an investment now for the near future and the longer range future. And I think sometimes in healthcare, we have a bit of a bias towards action, and sometimes we want to see something administered and we want to see it pretty quickly. And sometimes innovation, when you invest in innovation, it isn't always a quick process. And Marlene was saying, you need to think about the organizational culture and how that's going to develop, and that can take time. So
how long time? Sorry for interrupting, but how long time it can take?
Oh, it's a bit like a glacier. So it can go very, very slowly, and then you can have very quick movements. So it really depends on what's happening in the context you're in. But I think what you need to think about is how you're going to nudge that culture. So what kind of things are you going to put in place? What kind of incentives are you going to put in place for staff? How are you going to train staff, leaders, all parts of the system in terms of education? So it's about those different nudges and how you can influence behaviours. You talked about role modelling behaviours, really important as well. So all those things will help to build your culture. But the other important thing about innovation, I think, that we don't talk about enough, and we're seeing a lot, our context in Children's Health Ireland, similar to Copenhagen, is that we're building a new children's hospital. And we started before Copenhagen, and they'll probably finish before us, just to say. We're still waiting for our new building. And so we've got 3 of the Dublin children's hospitals that were previously operating with some collaboration, but mainly independently. And they're now coming together to move into a new building, which is amazing. And there's loads of innovation built into the building. And now we're thinking about, okay, how are we going to behave in that building? So it's not just about having cool tech and, robotics and things like that. It's about how can we actually behave in that building. So, but we're obviously in a really difficult environment post-COVID, and we've had lots of challenges in paediatrics. We've had a couple of very difficult winters post-COVID as well. So resilience is low, and what we're finding is innovation actually provides hope. It gives people energy, and when you're dealing with your day-to-day daily grind, if you have something that you can work on that is pointing towards the future, that is going to make a difference for children and families, because that's why everybody, in my experience, comes into work every day in paediatrics. It's a very special field to work in, is to make a difference for children and families. So that piece of hope that you can provide through innovation and innovation practice is really important, and that's worth investing in as well for your staff.
I really loved your remark about this innovation as a hope. Excellent, thank you. Waltz, I would like to ask you also about strategy and innovations. How do you see in your role how to make innovation as a part of your toolbox in strategy box?
Well, I think if we look at the building blocks of our strategy, so obviously innovation is inevitably part of every of our strategic pillars. So very similar to many other hospitals, I don't think it's very unique, but we have like those 5 pillars, which is excellence in treatment. So innovation is obviously part of that. Patient experience, so obviously part of that. Then motivated staff, which and strong teams. Obviously, there are ways how you facilitate that than the hospital, who teaches, learns, and drives innovation. So innovation, even the word is there. And finally, financial sustainability. So, and like living in a health system for decades, which is scarce of resources. The healthcare, at least in our country, always had a lack of resource. So you inevitably need to find innovative solutions how you move forward, and that will not change. So you need constantly to find the ways how you do either more with the same resource, or you do the same with a less resource, and that's really part of the innovation. And so, and coming back to the role of my role of any CEO, I think it's really the pivotal role, because you need to encourage people that this topic is important. It's on the table, but it's much more than that. It's much more than like having that vision and have that agenda that we need to move forward, etc. So it's much about the culture, as you mentioned. So it's much about the culture which allows also failures sometimes, which is not easy. We are state-owned enterprise as an organization, so which is not easy to allow for failures in a state-owned enterprise. You can be punished severely. Yeah. And you need to find the ways how you still find a place for those failures to be possible as part of your journey. You cannot guarantee that everything will be all right. Then obviously you need to provide the sufficient space in terms of the time and place and other resources for those innovations to happen. And back to the culture, I think one very important thing which you need to promote is really the learning to collaborate, which is not always the true. We are not always very skillful in this lateral collaboration, and that's something which we need to promote as a part of the culture. And I liked actually your question regarding how long it takes. Who knows? But I really believe that with the innovation, we need to do the things, and then at some point we will see the results. And that reminds me that story about this specific type of bamboo, where you need to water it and provide some minerals, etc., for a few years, and it only grows the roots below the surface, and then suddenly it starts to grow like several meters, like a week or something like that. So I do believe it's something similar with the innovation, because you need to provide a lot of prerequisites before you will see the fruits of that.
Okay, let's take one very good example. You already mentioned this ice cream with electrolytes. So how was this project? Was it just from the nowhere? How long it took? I understand it's quite easy from the one side. From the other side, it's totally not easy project. How long it took?
It was years. I wouldn't say 10 years, but close to that. So these were years. And obviously it wasn't really the project which was initially started and positioned as innovation. It was just driven by the willingness to help specific type of the patients and to provide solutions. So it wasn't really patented, etc., etc. So it was just trying to find a solution, and and so as I said, you are learning through that. And actually, we talked about innovation. So what is the innovation? And innovation is also a learning process. If you innovate, one of the outcomes, besides everything which you get as a product, is also that learning of your failures, of your successes, and you're definitely getting smarter, and that's also a very important part of the innovation.
Very interesting. How often innovations are happening unplanned?
So, you mean serendipity? Yeah. So there should be element of that, but you need to provide opportunities for those unplanned innovations to happen. So these can be, but it starts, I think, with a broader idea that you want to achieve something, and that, as I said in my opening speech, I think when you are clear about the unmet need of the patient, so there is a plan which you have in front of you. So because you want to improve something, and so it's already a plan.
And can you comment on unplanned innovations? How often do you see them?
So I totally agree with what's out there. I think we see innovation bubbling up all the time, but if there isn't somewhere for that support for those innovations, then often what will happen is maybe they'll be implemented through sheer grit and determination and passion of the innovator or the people trying to innovate. But often, if somebody leaves or moves on, then that project dies off. So or people just give up because they're meeting too many barriers. So there really needs to be that environment that's fertile, like the bamboo example. That it's really a fertile environment for innovation, so that when you do have these bubble up moments, and I think sometimes that happens when you bring groups of people together to start thinking about. What are the challenges that we're facing, including, patients and families and industry partners and universities, all these different areas of expertise coming together. That's really where you start to see a real bubble up of possibilities and ideas and solutions. And if you don't have the right structures in place to act on that and build on that, you'll lose an amazing opportunity. So I think that's really important.
Melanie, how often you have seen unplanned innovations?
Well, maybe all the time. Not that I can think of a specific example right now, but I would actually like to challenge your question about how long does it take. Because by asking that, you say there is a starting point and there is an ending point. And I don't think we see that in healthcare. Of course, when we build a new hospital, it starts and it's finished at some point. Hopefully, eventually. But with most other things, and it's the same for research, it never stops. And it's hard to say also, when does a project start? When does the idea start? When are you done? You will always get a new idea and continue working on that. So if you want to work very much with projects with a clear definition of start and end, don't go into healthcare. Because that's a long-term, takes a long-term commitment. So I think we need to think of this as a modus operandi, a way of thinking, and a culture, as Anne also said. And so yeah.
Wonderful answers. Thank you so much. When we are talking about innovations, at the moment, it feels like you have half of your staff have a title innovation officer. So let's be honest. How big is your team who is working with innovations?
I get the number from down here, 10.
Okay,
but
yeah. Okay, but
yeah, but I mean it's not only the innovation department working with innovation. They support it. We have many clinicians out in the entire organizations who have small or big scale innovation projects going on.
And how big is your team?
Small. We started with 2. Now we have 6. Just maybe 7. We're recruiting a 7th, and it's a mix of project management support. We have designers, we serve as interaction designers working with us. That's a fairly recent addition. That's been amazing just to see what they bring to the team and their ideas and creativity. And then we also have clinical engineering and that side of things as well. So yeah, it's a small team. We're hoping to grow, but the challenge is funding, support. So a lot of our funding is coming through grant funding and external sources.
Walt, how big is your team of innovators?
I would have a challenge to name a specific FTE, because I think we started from a approach of the kind of a chaos, where innovation was part of interest of some people, and they dedicated some time of their day for the innovation and for the tasks. So now we are moving towards more structured approach. So there are some people where innovation is part of their title, but nevertheless. So I think it's important really of how big is a broader team, because you cannot really put in place the innovation officer and say go and innovate now. So the key task is really to have that innovation mindset as broad as possible in the organization, so that there are many people who kind of dedicate at least part of their brain to that innovation agenda.
How it's possible? How you are doing it? How you are delegating? Okay, we all will be working with innovations from today.
Easier done than said, but what we see is, and that's, well, I think we will face it quite soon, that people, especially young people coming to the hospitals, they are not coming just like to perform one task, like to do the surgeries or something else. So more and more people are interested to do many different things, either to educate somebody or to innovate themselves or to do research, etc., etc. So that's what we need to prepare for, and therefore I think like building also the skills and educating, or just inputting this effort to build that knowledge in a broader organization. I think that's one of the crucial steps.
Yes, I'm slowly moving to the question about how to balance the need for innovations and the mandate for it. How to argument to the stakeholders we need money for the things that can fail. It's very, very bad in children's hospital, but it can happen. And how to get this money. Of course, nothing happens without money. Okay, we can go with our vision and very, very passion to do some nice things, but we all need to some food and to pay some rent and etc. How to argue? First question: how to argument? We need money for innovations, and how to mandate it in the hospital.
First of all, I think if we would operate as a silo, as a state-owned enterprise, as this type of organization, I think that's not possible. And therefore, our solution obviously is related to the partnerships and building even more partnerships with universities, with industry partners, with other hospitals, attracting funding, attracting like charity funding, attracting the different ways of resources. And that's part of also our vision to develop this healthcare advancement center and partner with other organizations. That's the only way how we as a hospital can promote and drive forward the innovations.
And what's your answer? How you are dealing with this balance on the mandate for innovation and financing it?
I think it's very challenging, and I can't speak, I'm not on the executive team, or I can't speak for the funders, but you know, the challenge is how do we keep our health services going, and that can be challenging at times. So then to say how can we fund innovation, sometimes that feels like a difficult ask. And I think probably in my own country, there's probably more funding available for innovation projects, but not so much funding for innovation roles or innovation support. And I think that is, you know, that can be quite challenging. So sometimes, you know, there's grant funding available through our central, our national health system, but there isn't always support for anybody that wants to take up that grant funding and actually do something with that grant funding. So, you know, we are working with a network of healthcare practitioners in Ireland across adults and children's, and we're trying to really influence that at a national level, but it's very, very challenging. And I think anybody who's I've worked in healthcare most of my life, but my background is in organisation development, and if you don't have a clinical role, you know, you're nearly always questioned, what do you do here? What is your purpose? So it's, you know, if you're coming in as an innovation support, you have to be really clear about what you're delivering, and we can make a really strong case for that. But it's difficult, it's challenging for funders with so many competing priorities.
Melanie, maybe you have some good answers, some good arguments how to deal with it, some good practice.
Well, the Mary Elizabeth Hospital has only become a real due to a very strong public-private partnership. So without that, it was never going to happen in a way it had happened. So partnerships towards industry, definitely. But I would also, again, like to challenge it a little bit, because, I mean, one of the reasons that we want to do innovation is that we look into a future where we're not going to get more staff, we're not going to get more money, most likely, but we will probably have more patients, also in the pediatric section maybe. So we need to innovate in order to be able to do what we do now with more or less the same resources. So we can't just call for, please send more money. Of course, that would be lovely, but I think we need to find innovation projects that can actually fund themselves. That's something we have a lot of focus on at our institution. So maybe they'll need a hand in the beginning, but then hopefully they will actually end out saving staff time, saving money in the end. So there is this phenomenon of frugal innovation, and I think that's really interesting to look towards places where they might be in more dire straits than we currently are, and get inspiration from there. So, yep, small challenge.
I want to hear about this innovations that can fund themselves. Can you share more about it?
We don't have it, as far as I know, within the pediatric area, but we are looking to install platform trials in the hospital. So that's a way of doing research where you can test several different interventions on one time. And for example, some of them are focusing on dose reduction in hematology. Some are focusing on scaling down the numbers of days that you do. Oh, now I can't. Do something. Can't remember the English word right now. So that means if you can actually prove that you can get the same effects with less of the dose of the drug, you'll save money quite rapidly, because these are very, very expensive drugs. So that can pay for the next trial, so to say. And if the patient needs to come in only twice a week rather than 3 times a week, you will save money, you will save staff time. So that's one of the tools that we are looking into. Of course, this is a huge challenge also culturally, because we are used to thinking research as an area and also innovation where we want to do more, we want to do it better, we want to do it smarter with more cool technical devices. I come from radiology myself, so I look very much into how can we get a cooler scanner, a better scanner. But I think we need to think differently now. We need to think about what we don't need to do, what we can do with less rather than doing more and more.
Yes, it's totally clear that we don't need innovation just because of the innovations, and that the center of it is patient, small patient, that is not small adult. So how do you see, what are the biggest gains for patients from innovations?
Of course, we need to focus on the patient. Actually, I just got an email this morning about a press release saying that now we can scan 8 pediatric patients on our MR scanner a day rather than 4. And I was like, that's good. But the reason that we can do that is because I found a way to avoid GA in the patients. So what I think should be the focus of that press release is that the children can now be scanned without the use of GA, because that's a huge relief for the children, a huge relief for the parents, and also a relief for us as a system. But I mean, that's second. So I think actually, I mean, patients, children, families that don't want to spend time at the hospital if they have an alternative, they don't want to get more drugs than absolutely needed. So I think we have a common ground here, and that's also why it's so important that we involve patients, we involve the families in the discussions about how we move forward towards a more efficient healthcare system, and patient-centered, of course.
And what else we can get for patients?
Yeah, I think it's really important that we keep the focus on impact, you know, and what kind of impact innovations can deliver, because sometimes we can be a bit seduced by the technology and what's out there. And I think AI is, you know, a perfect example now that there's so much opportunity there, and everybody's looking at that from an innovation perspective, but really thinking about what difference is this really going to make for children and families, whether that's a direct impact or an indirect impact. And, you know, again, thinking about how we involve, exactly as you said, how we involve children, young people and their families in the development of innovation is really important. And it was great to see from the earlier presentation, final use has been included in the development of innovations. And we're finding that's really important and really valued by patients and their families. Being asked about, how they currently experience healthcare, what their current pain points are, their current challenges are, and then using that as a springboard to look at how can we innovate in this space. So, and that's something that patients and families want. It's something they expect, and I think particularly parents of children that have chronic conditions or complex needs are, they're out there, they're researching, they're advocating for their child, they're looking to see what's available, and they expect us to be innovating. They want to see what they see in other areas. So, that's definitely an expectation that's growing.
Walt, what could you add? What can patients gain from innovation?
I'll just build on what Anne said, but before that, well, we discussed about the advantages of innovation from my perspective, so there are still directions where we could add is improving the access. So how innovations can improve the access and the quality of the care. But I liked very much your point regarding this empowerment of the patients to be part of or responsible of their care, and we all know about this non-chronic disease epidemics or pandemics or whatever we call. And clearly, these are the diseases like being overweight, etc., where nobody from outside can really solve your problem. So the only way really to get rid of those problems or to reduce these epidemics is to find the ways how the patient is part of that solution, and that would be like a true innovation. If we can find that, that would be the biggest step. But I like your point regarding the talking to the patients, and that's exactly what I want to stress at the end, because what we see in our hospital is that sometimes the companies come in with some of the solutions, and I have a feeling that there hasn't been too much of the interaction with the patient and understanding the patient need. And that's something which I would encourage everybody and anybody to have those very, very tight and close cooperation with the patients and trying to understand the needs. And sometimes, well, you said about this finding innovation like an accident or something like that. I will try to link it to one short story. Yesterday I was passing by the cafeteria, and there was a guy like eating lunch, but there was something strange about him. He was moving a little bit strange, and then I realized that he was speaking on a phone. So he was a phone in front of him, but he was deaf. He was a deaf man. So and he was speaking on a phone. And you imagine, so when we were talking about our phones, so the function that you can see the other person, it's nice, yeah, but it's not life-changing for most of us. So still, I use it like a minority of times. I usually call, but for somebody, that innovation is really life-changing. So deaf man speaking on a phone, that's life-changing. And that's why I stress the importance of talking to the patients to identify those patient groups where your innovation can be really life-changing. Yeah, that's.
So we are almost out of the time. Last final question. Very, very short answer from you I want to hear. So the answer is, the question is, 10 years from now, what are the innovations you want to see in Children's Hospital? Very short, very quick.
I'll be very quick because I'm aware all the time. So innovations which serve the patients.
I will be quick, but two. I'd like to see an innovation team in every children's hospital.
Yes.
And I'd also, the other big pain point we're hearing from children and families is needle procedures, so non-invasive devices that could support and minimize the need for needles.
Yeah, for me, I could totally concur with what have been said, but also devices supporting treatment and diagnosis at home.
Wonderful. I want to see this future tomorrow. Thank you so much.
All right, as the panelists disperse, we are preparing for another keynote, and it has been said time and time again that innovations are not just about these crazy technological skateboard tricks, right? They're usually quite dangerous, and they look cool, but might not be serving a function. This time, however, we have someone who has pioneered several different innovations, especially in the field of technology. And I heard this story from the organizers about this 1,000 square meter underground facility, a literal Batcave, as the name of the speech implies. And this Batcave, well, it is highly prolific. It is not only creating these AI solutions, collaborating with the tech industry, but they also even allegedly have a corner of the failed innovations, which is actually like a museum of some sorts, which shows how much they have worked and how many times things have been attempted to be implemented. So to speak more about this specific Batcave, how to build it for your own needs, and definitely not because you're extremely geeky and interested in this, Ian Hennessy, Clinical Director of Innovation at the Alder Hey Children's Health Park.
Hiya. I've never had a panel discussion set me up better than that panel discussion we've just had there. So I'm going to be talking genuinely about how to build a Batcave. Not only because we built it, but also how you can build it as well. Now, I'm being a bit facetious actually when I talk about Batcaves. What I'm talking about is really how do you build something new. And the thing about new things is they're often ridiculous. All new ideas are ridiculous to start with. But how do you go about getting through that pain barrier of that's a ridiculous idea, Ian, you can't build a Batcave? That there is an element of being super geeky. You know, that was part of it. Now, some of the things which I love about innovation is I love about how vague the definition is. Nobody can actually agree on what innovation means. So before I kick off, I'm going to tell you what I think it is. And by me, I actually borrowed this from one of my trainees who told me, and I just really liked it. It's about a fresh idea, not necessarily a new idea, a fresh idea, that has been actually implemented that achieves value. And notice I've not said money. Value is a key part of it. Now, like all things, you're going to need a little bit of context. Now, Liverpool is where I'm from. Well, actually, I'm from Scotland, but I work in Liverpool. Now, Alder Hey is the main children's hospital in Liverpool. Now, you're going to have to throw your mind back, about 125 years to get the real context of this. So before the Americans ruled the world, the British did. Okay? a much more civilized era. And at this point, a third of, yes, Pax Britannica, sorry. No gunboats, sorry. A third of the world's trade went through Liverpool, our city in the northwest of England. And now, this was like actually the headquarters of the White Star Line of Titanic fame. And with huge amounts of money comes huge amounts of poverty. And we were the industrial heartland. And we had lots of sick children. So that's how Alder Hey was built. Now, if you look at Alder Hey Children's Hospital, it kind of looks like a Victorian poorhouse. This looks old, doesn't it? And it actually looks very like some of the older parts of your building, except it's in red brick rather than yellow brick. But this old building, which did some amazing things, was really holding us back. It'd been there for 100 years and some amazing stuff. One of the best hospitals in the world, I think. But the infrastructure was holding us back. So we built this place, which is our new children's hospital. In this place, I feel like I've been given the keys to the NHS's Ferrari. Okay, this thing is incredible. It's like primary, secondary, tertiary, quaternary level care, cardiac services, major trauma centre, interventional radiology. We've got it. And it serves 6 million people. Huge area that's served by this hospital. And it's got all the latest digital infrastructure built into it. And another thing I like about it is it's very beautiful. And it's been built into the park. That is grass going up onto the roof above us. That's the interior of it. I think it is quite Scandi, actually. People have described this as a boutique Norwegian airport. There's one quite like that. But it was designed to not feel like a hospital, and also to be impressive. So when parents walk in, they're like, I am in the right place, which I see very much when I went and visited the kids' hospital yesterday. I loved the A&E department because that inspired me with confidence. I'm like, these people know what they're doing, and this is where I want my child to be. And it's nice, you've got lots of lovely patient bedrooms, views of the park. It's definitely 4-star. Our intensive care unit has lots of lights in it. Again, there's so many parallels between the Latvian hospital and what we did. We've got, infinity grass decks for play decks on the end of every single ward. They've really put patients and families at the centre of their thinking. And it's not just a hospital. It is an entire health campus. We're about halfway through building the edge of this now. It's been almost 10 years since we've opened our new hospital, and we're still building. And it's everything, community hubs, everything else. Now, I'm going to talk to you about how we got a Batcave, and I'm going to put it in the context of fresh ideas implemented and achieving value. So in 2014, this is the fresh ideas stage, just at the very start. And this is the first ever picture that I took when I started my job. This is the map room for the new build for the hospital, and I'd been given a job as deputy clinical lead for IT, half-time surgeon, half-time doing IT, because I'm very geeky and they wanted new geeky stuff for the hospital. The innovation was not part of my job title. I just made that up and changed my business cards and changed my email title. Nobody noticed. Nobody noticed. Just did it. And didn't know what to do. I actually made a parody video of the hospital management's latest strategy on my first day. I've still got the video. I'll show it if you want to see it afterwards. And the first thing we did was like, I don't know what to do, let's have a hackathon. So we had a hackathon. And this started to generate lots and lots of ideas. And lots of staff got involved. We did it at a local football stadium, Everton. They gave us some space. We got lots of staff along. And it created a big buzz. Everyone was loving this, coming up with new ideas. Nothing really behind it, but we just started that way. But what that did was it started to attract universities, and the universities started coming to us with new types of tech and new types of ideas. So that's me trialing, like a really old school VR headset there. This is back in 2015. But it brought technology to the hospital, and you could start to mix it with the clinicians, because they were interested and activated and excited. So we're like, oh, this is good fun. And then we started attracting companies. And this was interesting. So this is our first baby company, our first incubated company that came and worked with us. They knew nothing about 3D printing. Well, no, they knew nothing about medicine. We knew nothing about 3D printing. And they came and we worked together to create 3D printing for medical applications. This company now has got about 7 different hubs around the world or in America, but they started with us. And it's been a great partnership over the years. And then we won an award. So we got the attention of the management, which was great and bad, but great mostly. This is the HSJ award, which is like the Oscar that you get in the UK for the best thing. We completely winged this. We totally fluked this award. But that got attention from the management. They're like, right, okay, there's something in this innovation thing. Maybe we should be backing it more. And then we did a hackathon again, but we did it with MIT. And we did it with MIT because we just completely, what we call brass necked it. We went and visited them and invited them and said, come back to Alderhay and do a hackathon with us. And amazingly, they said yes. And when they did this, every geek for a 100-mile radius descended on the hospital, and we had like the biggest innovation party you've ever seen. It went on for 2 days, and the chairman loved it, the chief executive loved it. It was great. Now, I jumped ahead. Now the problem was, because we'd made innovation up, because it was just 2 years before we moved into the hospital, we had nowhere to go because an innovation department didn't exist. And I'd already taken over a part of the old hospital to make an innovation hub there. I just used the disused ward, nowhere to go. And the head of the hospital development said, I've been under the hospital, and there's this massive area that they're going to brick up. They're going to seal it off because they don't need it and they don't want to pay for it. do you want to come and have a look? So I went down underneath the hospital and found this, 1,000 square meters of dead space underneath the hospital. And I was like, oh man, this is amazing. I thought I was going to just leave it like this. Right? I'll put a couple of tents up. It'll be like the Batcave. It'll be like really edgy, and like, we'll invite people down in secret. We'll have like a pole, to get down there. But then we managed to actually raise a load of money. And we raised a load of money to put a floor in, put electricity in. But you can see it was a blank canvas. We had this 1,000 square meter space. I had one table in it, this blank canvas to kick off with. Now, we call it the Batcave because that's what it looks like, and that's the Batcave. Okay? So, us, Batcave, us, Batcave. Yep. I mean, I genuinely have to pinch myself that we got away with modelling it on the Batcave, but we did. It's from The Dark Knight. Yeah. Look, I couldn't believe it. Could not believe that I'd got away with it, funded by Innovation Hub, Innovation Agency. Now, this is all well and good, but this is not sustainable. Okay, we winged it for about 2 years and made a lot of flashy bangs and noises, but we weren't implementing anything. We were creating ideas, but we weren't going anywhere. And now I'm a clinician, so I was then introduced to the concept of a project manager, something I had never heard of beforehand. And it was like, okay. And then we got this thing called European Regional Development Funding, which we now don't have, but at the time was super useful for hiring project managers. So we could actually implement things into the hospital. Now, that was our team back then. So a relatively small team, but we got a fair bit of money from the European Union. And we started putting things in and actually implementing them so they worked. So we were putting in virtual reality rigs, and this is in our virtual reality space that we had. We did a deal with a theme park where we created an Aldehay hospital within the theme park that the children could be surgeons at, and they could be A&E doctors. That's my daughter doing a liver transplant, not paying attention. Yeah, but it was, it was cool. We're doing all this stuff. We're expanding our VR offer. I mean, this was one of the platforms we were experimenting with at the time to do interactions quite a long time ago. Although this actually currently is a failed project. I can speak about it at length afterwards. But it was interesting. We were implementing stuff. And this was our biggest implementation project that we did. We were going to create an app for the hospital that was a digital front door. How to put it, you could log in, you could look around the hospital, you could get badges for having treatments done, you could learn about us, you could put your profile in. It was gamifying the care process. And it required a huge amount of input with the clinical teams to try and implement this into practice. And this is where the project management approach really came into its own. How do we get stuff so that it's actually in the hands of the patients? Because an idea is nothing unless someone's using it. And then we did this thing where we worked with artificial intelligence, which at the time was like, what has artificial intelligence got to do with medicine? This was 2015, and we did the world's first implementation of the IBM Watson chatbot. So we had a chatbot built into the app, and we did that over a couple of years, 2015 to 2017. And at the time, everyone's like, this is weird. But it put the roots in for our eventual AI team. And we had this, people could interact with the hospital and have a chat with it. It was just incredible. And we were very lucky to have a supercomputer facility just up the road. And then we started doing robot wars and patient and children events. So we just asked Hasbro, and they loaned us Optimus Prime. I got in a lot of trouble for this because to drive to the outside of the hospital, you've got to drive over some of the grass. I hadn't realised just how heavy Optimus Prime is, and it ripped up a load of the hospital, and I got in a lot of trouble. They forgave me because the event was very cool, the Robot Wars thing, but it was a part of it was for me. I got a lot of pictures of me in the cab for this. And when we worked with, this is the British thing. This is a famous doctor in the UK who does a television programme for children. Called Operation Ouch with the BBC. Oh, and then we started making weaponry. So this was a big thing we did. So we did this for the UN. We started 3D printing weapons so that they could take them to schools in these areas and say, look, don't touch this. If you find this cluster bomblet or this is a mine, and you can make personal ones for that area. And at one point, our entire hub was filled with Chinese anti-personnel mines, and I had a bit of explaining to do on that front. These are actually rocket-propelled grenades and artillery shells for teaching people how to defuse them. But hundreds and hundreds of these we produced. And this is me trialing a new type of 3D operating microscope using a 3D printed child's penis for a hypospadias repair. And we created 50 of these penises, and I had a lot of explaining to do as to why there were 50 children's penises lined up on our 3D print hub in the Innovation Hub. But good, because we're actually using it and getting it out there. Now, again, this is all very well and good. We were coming up with ideas. That's great. We were engaging people. That's great. And then we were getting it so that people were using it, which is great. This, however, still wasn't working because we were not making any money. And we were also not measuring the value of what we were doing. So when people said, what's the value of this? And I was like, well, I don't know, it looks cool. But that doesn't cut it with the hospital. So the next phase is the achieving value phase. And this also coincides with our European Regional Development funding getting removed in 2017 for very obvious reasons. We now had to make some money as well. So we're like, right, we need these things that I was also not aware of called accountants. And we had to get accountants and commercial people onto our team. So the team expands. The hospital, and this is great of them, double down on innovation. They go, right, okay, we're going to back this. We're going to put financial people in and commercial people in, and we're going to keep on going. So we're adding in accountants and people with commercial experience into what we're doing to be able to, look at the value of what we were doing and make some. And this is where we were starting to go in, 2019, going into 2020, we put this team in, great, pandemic. Yeah, so it's like, okay, this could be a problem. This was our virtual reality suite, which had been turned into a food storage area because everyone was like convinced we were going to starve in the hospital, weirdly. And you'd think that this is going to completely flatten our program, but it didn't, because what you had in the hospital was a big team of problem solvers who suddenly had their muzzle and leash taken off. And we went absolutely crazy. Still one of my favorite periods. That was the amount of PPE we generated. We actually started making this stuff. We never got anywhere close to running out of visors. We had that knocked out. We weren't even 3D printing them. We were like industrially producing them within 2 weeks. We had deals in place. We had 20,000 coming off the line. We went absolutely crazy. We did 48 prototypes in this period, 12 implemented into care, 4 of them commercialized and generating income. And it was just basically we had the gloves taken off. So this was an amazing accelerant because the innovation team was in place, it was bedded in, it had its roots, it had its connections. I was phoning up manufacturers that I already knew, designers I already knew. The team was there, prepped, in position. And there's so much stupid stuff in here as well, don't get me wrong. Okay, there's like things which are like so laughably dangerous, which I'm glad we never... Actually, there's this one, where is it? It was the powered rebreather mask that really had massively high levels of carbon dioxide in it. And when I tested it, and anaesthetists were laughing their backside off at me, and like, obviously this is going to kill you. So, but we canned it. We never used it on anyone apart from me, so it was all right. We did loads of things, like we did visors made out of the same production that you make Easter eggs. The container, the clear plastic container. We made thermomolded visors out of that. It's clean, so it's food grade, and you can make 90,000 of them in 1 week. There you go. We did that. Actually, the one that made us the most money was the cloth mask, actually. We used the last cotton mill in the UK to make face coverings and then sold them at a massive profit. And we did it through the charity and through ourselves. Lots and lots of things in here, and it was a lot of fun. Now, and that was the one that was actually the biggest product, which was a clear mask. One of our speech and language therapists said, can't do my job, people can't see my face. So we created a prototype, and then because we had an innovation team, we could hire a designer, protect the intellectual property behind it, and do a commercial deal with a manufacturing company to make it. And this is it, being sold at conferences. This is my first ever modeling gig. I don't know if you can see me, top left hand, yeah. Face for radio, I know, but you know, that's how desperate they were. But again, it's because you had an innovation team, you could do this, but we didn't quite do this fast enough to make a silly amount of money, which is a shame. So we kind of missed the market. Now, because you've got project managers and accountants and commercial people, you're starting to create systems, okay, to actually really embed this into what you're doing. Okay, it's not just, you know, crazy ideas. And then you start, but when you get this all down, you know, with being quite grown up about it, you start getting venture capitalists getting involved and people who want to fund things and get involved in it. So this is where the value really starts to get generated. And that's us doing a tour for venture capitalists. We get really embedded into how the hospital works. We're building a new unit, our innovation hub. We printed out all the floor plans. We brought all the teams down. We looked at how the technology goes into it. Saved a lot of money in the design process by doing this. We started creating, we've got an entire AI team by this point, 10-person AI team. We start creating algorithms which allow us to, machine learning algorithms, so that we can go, oh, who's not going to get brought today? Yeah, I mean, it's interesting, I saw that was one of the projects the Latvian team were doing as well. But we can predict with 80% accuracy who's not going to get brought in a specific outpatient clinic appointment. So then we can phone them up and send them transport. We created Little Hearts at Home. And this is something that David can talk to you at great length about, but basically we have lots of congenital cardiac children. They have very expensive operations and they have to go home in between. We didn't have very good eyes on them. Let's create a digital platform so we can monitor them at home, so we can get them home earlier, and when they're home they're in a safer position. And we have taken this and we're now selling it on to other hospitals. It's a commercial package. We're using it, we've implemented it, and now we're selling it on to generate the value and measuring the value of what we are creating. We created the CYPS1, a mental health platform for smoothing the process by which you interact with our hospital. How do you get into our hospital? You know, how do you, from a mental health point of view, there was 13 different ways. Let's make it one way. Let's have the educational resources available. Let's make it a digital platform, which again, we've spread out. You know, we're measuring the value on it. So now you start getting focus of like, what do we do? What are our focus areas? What is our strategy? You know, let's make it more, I don't know, maybe grown up is one way to describe it, but you know, your partner ecosystem, which is the foundation of what you've done. And it gets built up over years and years and years. It doesn't just happen. But it is valuable. I've not quite got a handle on how to measure the value of that yet, but we know it is. I've got a lot of metrics. I'm not going to talk through it, but I actually have them now. That's key. We can articulate, you know, what is the value of what we are doing for the hospital. And the team grew and grew and grew until we got about 30 full-time equivalents with, you know, through the innovation team. They are professionally branded. We have standard operating procedures. And now we have a Batcave which has been refurbished. So it looks a bit prettier and it has things in it. So we have our 3D print zone, we have our rapid prototyping center, we have our workshops, our virtual reality areas. We have an entire business-to-business brand. This is us doing corporate training. I think this is for an energy company. About how do you do innovation, because innovating in healthcare is basically as difficult as it gets. So if you can do it in healthcare, you can do it anywhere. So that is our timeline. So you see fresh ideas, 2014 to 2016, roughly. Implementation, ERDF, 2015 to 2019. Commercial phase 1, massive acceleration with pandemic. Commercial phase 2, and now the phase we're in at the moment is, how is this just the way that Aldehay is? This is we are innovative. This is what we do. We are a core part of hospital strategy. How do we integrate with research? How do we integrate with digital? How do we integrate with transformation? How are we just, this is just what we are, and actually mean it, with words and actions? So, how to build it? Okay. The key thing that you need to be able to do, I think, for doing this type of ridiculous stuff, is you need to be super persuasive. Okay? And being persuasive is actually not a new thing. Okay, this is an old idea. So I just use the old Greek methodology of ethos, pathos, and logos. Ethos. We are children's hospitals. Okay? If you are a parent or a clinician at a children's hospital, you can speak with incredible authenticity about, how powerful is your message and the purpose. This is something we do not use enough of. This should be our sledgehammer. So you must use your ethos. That is, your authenticity as your leading kind of factor when you're persuading people that they need to do this. Pathos. This is the emotion. Again, we are children's hospitals. If we cannot generate emotion out of our message, we are not doing our job well. This doesn't get used enough. You need to use the patient stories. You need to use the pain of the people who experience the problems. This is critical for getting leverage and getting people to help you. And then logos, this is the logic. This is overused. People often lead with the logic when actually people want the emotion, and then they want you to say, just give me a reason to agree with you. Okay? So you need some stats, but don't lead with it. Okay? We often go with trying to go market size, this, that. Actually, it's like, there are a lot of sick children here. Do you want to help us with that? It's a powerful message. And my favorite, Kairos, luck. Right? Serendipity is a wonderful thing, and we have been very lucky over the years. And just use it. Okay? It's amazing. And then what you'll find, and I'm going to just get this all up because it makes it easier, is we've got us in the middle, the innovators. Your job is to interact with the outside world, because hospitals don't do this very well. You do not interact very well with the outside world. And then how do you engage the hospital? Now, what I have found is that the hospital, if you try and attack middle management directly, it will not work. You will bounce right off that. It doesn't matter how persuasive you are. You need to go to the top, and you need to go to the bottom, and then you need to squeeze the middle. Okay? It's a pincer movement. You have to have the clinicians going, why have I not got this? I want this. I want this. Bugging their managers. And then you want the corporate guys to put this thing, which I had also never heard of, a KPI, into the middle manager's strategy, so they go, I've got to have an innovation project. And then the clinicians are going, well, there's this thing which we've just been told about. And it's great when you plant both things at the same time and you watch it squeeze into the middle. I watched this because our new manager in surgery, she didn't know I was a director of innovation. And she came to me and she said, Ian, look, you're quite an innovative sort of guy. I'm getting absolutely bugged about having an innovation project for general surgery. Can you think of one? I'm like, let me have a think about it. Out it came. And you need to be able to work with the small, big companies, charities, everybody else. Bring them in. So, thank you very much. And I think we're on to our next thing.
Thank you very much, Ian. Oh, I will have that. So, this is a metonym for what's coming up. It's a coffee break. 25 minutes, see you here at 11:25 and hear more talks. Don't forget to catch everyone you want to catch during the coffee break. See you in a bit.
Christmas lights fill the city. There are people everywhere. The snow is falling white and pretty as I stroll on my way to you. How would you feel about packing up today? Leave this all behind. Go get snowed in somewhere. You and me. I would rather be somewhere with you, without TV or phone. Is it wrong for me to want you for my own? This Christmas, let the others miss us. Let's go get snowed in. Let's go get snowed in. How wrong could that be? Being snowed in somewhere, you and me. Let's go get snowed in. Let's go get snowed in. How wrong could that be? Being snowed in somewhere, you and me. Let's get snowed in somewhere, you and me.
I think we can. Will you want a microphone in hand or on the stand? In hand. Okay. Hi, some of you arrived just on time and part of you were tapped on the shoulder with a very stern-faced person looking at you and pointing at the wrist. But whatever it is, the time is objective and it is 11:27. It is time for us to continue right before the lunch break, we will have exactly 2 more talks. And this one is by one person. And Ian mentioned something about in 2015, it's like, oh my God, AI, it's so new. How does this apply to hospitals? Well, now we have a whole speaker about AI in hospitals who is going to deep dive into this. And well, I guess I will welcome him, but he has already entered the stage. It's Andrew Taylor, Director of Innovation at Great Ormond Street Hospital for Children.
Thank you. So, thank you very much, and a quick thank you from me. So I would very much, Alice, you may not be in the room, but I'd really like to thank Dace for basically organising a really, really good meeting. So thank you so much. I'd also like to thank the previous speaker. So I would say in our journey, we're probably about 5 years behind Alder Hey. So always stand on the shoulder of giants. So you kind of copy what people do, don't you, so that you can do things really well. I think the other reason, sorry, I'm going to embarrass you slightly, Ian, here, is I'd like to thank Ian. So at ECHO, we talk an awful lot, or we get exposed to fatalities in children because we work with the hospital in Ukraine, in Kiev, and Marek from Poland clearly has lots of patients. But when you work in the UK, you do not expect to get a mass fatality, do you? But if you saw the news over the summer, clearly we had an incident in a place called Southport, which is very close to Alder Hey. So Ian was the surgeon on call that day and had to deal with that. And actually, often in the UK news, people don't really positive, particularly when hospitals have to do something. But actually, it came across how incredibly well Alder Hey had dealt with that. And one of my reflections on that is, I think part of the thing that we all do from an innovation perspective is we develop a learning culture, and it's very clear that there had been previous historic incidents in the Northwest that had happened, that learning culture. So, Ian, thank you for dealing with those children in a time of great horror. Much appreciated. So, AI in children's hospitals. Oh, there we go. So what is AI? So we know what intelligence is. We've talked about it. Why did it work during COVID? Because we had problem solvers. Actually, when you do it with AI, it's artificial. So a computer kind of does it. And I kind of think of it in 2 ways. You can either characterize something. So I have a dot on a chest x-ray, and a machine tells me that there's a dot on a chest x-ray. Narrow AI. Or, as more of us are seeing, but they're probably not used clinically at the moment, you can use something that begins to give you predictive AI. So it's going to tell us something that we don't know now that's going to happen. So really general AI, or the generative stuff that we're seeing. And clearly one of the things that's super important for us is that we evaluate and make sure the accuracy of this works. So if I look at my lab at the moment, if I measure potassium in a blood sample, every day the lab has a blood sample with a potassium of 4. They run it through their machines. If it says 4.2 to 3.8, everything's fine. If something says 2, we go off and work out why that. We don't do that we're going to have to do that as we go forward when we look at some of these algorithms. So what are the positives about it? We can think of thousands of examples about this, how this happens. I'm a radiologist. I think one of from Copenhagen earlier we said somebody's a radiologist. I write a report. At the bottom of my report, I put routine follow-up in 2 years. That report goes to our admin person, who sends it to a cardiologist, who asks their PA to book something through radiology, that then goes to another human being to put it into the schedule. All it needed was for that decision to be listened to, probably, and then it's automatically booked. But we waste so much redundant time, waste of time, with people doing completely menial tasks. So we know that we've talked about patient support, and we've talked about operational support, but we can think of loads of ideas around this. If I were to, actually these are adult examples clearly, look at mammography. I would argue, so in the UK, and I don't know how it is around the rest of the world, I'm assuming it's very similar. When you do screening of a mammography, you have 2 radiologists report. The data that's coming out from AI suggests you only need 1, you might not need any, dare say it, but you definitely only need 1 because the AI is definitely as good as the second reporter. My interpretation of the results, it probably needs to go a bit further, but it's not far off. And we see examples in pediatrics. So I think the first things that we're beginning to see it are going to be in imaging, whether it's in radiology or histopathology. And are they going to take away our jobs? Probably not, because there's a lot of expertise that we add into that. But they're going to help us, undoubtedly, and these are the sorts of things that we're going to see. So the positives. Now, if you're like me and you like kind of video games, when you watch Ready Player One, you think they live in a dreadful world. Actually, I want to be in the virtual world that they go into. But on the other hand, you look at Terminator, which is what everybody is fearing of, is we create these machines that then take over. just as an example of takeover. So I won't say which organisation, a set of colleagues of mine are on a meeting and somebody joins from South America. And that person in the background uses an AI bot and they're using it for good purpose. They want the minutes of that meeting for their own purposes to be there. Unbeknownst to them, that chatbot or that bot then goes through their entire Outlook and Teams diary, puts in that they're going to go to this meeting again without necessarily the person being aware. The next meeting that happens, the chatbot comes, but the person doesn't. Nobody knows, because some people don't turn on their videos, you don't necessarily look at the list. And halfway through the meeting, the bot sends a picture of everybody with the minutes of everything that they've spoken. Everybody, oh my God, what the hell's going on here? And so if you're taking the minutes, you're going, yes, this is fabulous. But as people, something has interfered, something external that I didn't anticipate is telling me what to do. And people find that quite scary. There are lots of things, but there are two things that people really fret about. So one is hallucination. So this is something that many of us may use, but a colleague of mine was planning for an interview. So went to one of the things that you might use and goes, please suggest a strategy for an abbreviated MRI protocol. So the answer comes back. Focus on the patient, personalize the scanning protocol, minimize unnecessary scans, optimize content. Please could you tell me a paper by Cutty that's about an MR protocol for tetralogy This is the answer. Now if you look carefully at this, there are some details missing. This is completely made up. This does not exist at all. The link takes you nowhere. It appears you've invented a paper. It comes back with this. Now this looks more impressive because actually these are two people who do actually work together. This is still not a paper. I've tried to find this damn paper everywhere. This is not a paper. It's completely made up. Very convincing. What's even worse is there's a whole backstory to why this happened and what happened here and what the paper results are. It's not. This is the paper it was trying to find. But it's so convincing. So again, we have to be careful and we have to have ways to monitor this. The other one that we're really worried about is bias. Correctly so. So we know that women have not been represented well in the science jobs. According to Deloitte, less than a quarter of technical roles. A company, a very large company, has an AI recruitment system that looks at all previous selection criteria. And the system learns how to judge from looking at previous CVs. You know what's coming next, don't you? All of those biases that were there in the past for why necessarily women didn't get those roles are now just replicated forward. And the solution thinks that being a man is an advantage in these jobs. We have to be very careful. So those are the things that we worry about. So one of the things that we set off very early to do was actually for our own hospital, let's create some AI principles. I'm not saying these are completely correct, but this is what we've chosen to do at this point in time. So they're inspired by the Hippocratic Oath, which actually is a very interesting document and much more than many of us think because it's got a lot about equality in there. It's very interesting. And Asimov's 3 Yours. We're into robotics, so let's use those. So it's fundamentally, we've got a benefit, so do no harm. We've got to make sure that there is equity and confidentiality. And for us, at this point in time, there has to be some form of clinical supervision. And actually, we've been approached by various companies, particularly in the AI chatbot world, but we've said no to them because we think that they're making decisions, particularly about how you filter patients. So at this point in time, that's a rule for us. And then behind that, we have a set of these principles, and they're all the things that you would expect. So be patient-centered. We must do thorough evaluations. If we do an evaluation, though, it doesn't necessarily mean another hospital has to do it. So those are important. Bias-free, cybersecurity, data protection, clinical focus, so on and so forth, to make sure that what we're doing is for clinical interest. And I think, though we've touched on an awful lot around the patient-centered bit of this, I think clinicians are super, our kind of byword is the child first and always. Actually, yes, completely get that. But a lot of what we need to do is to make sure that our staff are supported in many of the things that they do. So, what about a real-world example? And because at this point in time, I was kind of asked to write an AI strategy, and I went, I don't really know, I haven't done any of this, don't really know what's going on. So we thought, okay, let's work with somebody and see how we can take that forward. just to digress quickly, so this is the current investment in AI, so 200 billion. What is interesting in this graph is healthcare's not on that as a separate thing. You can see life sciences on there, but it's not. And almost all of that money, and we've kind of alluded to this in all of the things, goes to that little tiny red thing, which actually, for everything that we want to do, which is deliver in healthcare, is the rest of this diagram. And so for me, I'm very interested in how we make all of, somebody else will come up with some good AI tools. Little Ian's lab will do it. That's not necessarily my prime aim. I want to make that happen in the clinical setting. What do I need to do to make that happen? And so actually, if we go through those things again, I'm particularly an NHS focus here, there's no infrastructure to deploy. There are no people. We have a thing called Agenda for Change in the UK, which lists every staff kind of profession and their roles. There's no data scientist. There's no data analyst. So we don't have the, how do you do this financially? It will be a very different financial. Who decides who's good enough? I put an algorithm in, it's 95% accurate one day, it's 85% the next. Who makes that? Who says that? Nobody at the moment. And so we've got to monitor, we've got to validate. And then another thing, I see a patient and I tell that patient some information. They don't go to me, which textbook did you read to do that? But they might go, which AI algorithm did you use? Or more importantly, why haven't you used an AI algorithm? Because I believe it's better. And so I think most, or certainly our hospital at the moment, has this really chaotic way of doing stuff. It's just not focused. We don't necessarily have data design. We don't necessarily have the models. And so we know we've got this increasing requirement, particularly for data, and data underpins a lot of this. We know what we want to do. There's lots of government high-level things that say, wouldn't it be nice if we could do this? But actually not really the nitty-gritty of how we make it happen. So we worked, and they're here today somewhere in the audience. So we basically got approached by a small UK startup called Tortoise, who have an ambient technology that then links into a large language model. And the first use case for us would be, could you take that so that you could listen to an outpatient conversation and create a clinic letter instantaneously? So that's the, and what does that get rid of? You go to the doctor now, what do? You talk to them briefly, and then they type an awful lot on the screen. And then they've got to type up a load of admin stuff afterwards. Can you get rid of that burden? And so one of the things that we did at the very start of this is to say, there is a huge, electronic patient records are great for people like me who want structured data. They are a nightmare for clinicians. They're so boring to enter the stuff in. You have a nurse who goes into a room, who does the obs, writes it on a bit of paper, goes back to a desk, types it in. No, say it out loud, it's automatically in the record. How can we make people's lives work better? So as I've said, this is working with Tortoise. They were here. I think they'll give a demo later, Jasmine. And as I say, the idea is that you would listen to the conversation, ambient AI, put that into a template, and that template creates a clinic letter. So we decided to do this in 3 phases. Don't necessarily have to do it. So the first phase is work with this group to create a minimum viable product. So that's phase 1. The second phase, which I'll show you some of the results, was actually how do we test that? So the first one is let's create a set of scripts that we'll get actors to do. And with those actors, we will put proper clinicians. Okay? So that's the third phase is then to do it with 200 patients and clinicians. And we have a 4th phase, which I'll go on, which I think is how you then expand AI. So 48 simulations. So better. We spent millions of pounds on Epic. Our note quality, according to this, is 43%. Ha! You could spend 120 grand a year and get it to 100%, potentially. Now, a small study, take it with a, but actually, we've got better letter quality, and it comes back to how do we measure things? It was faster. So the amount of time you talk to the patient is the same, but you don't do the admin stuff. So actually, you could potentially see extra patients. I'd be very cautious about that, but potentially you could. It's kinder. You're talking to the patient, not typing to your computer. And actually, from our perspective, it's safer because now that data that comes out can be automatically put into the Epic record. So that things that we're interested in are there automatically. So for us, the next phase for this was, okay, we've done this in a tiny pediatric hospital, okay? How do we then do the bit we're all talking about? Because I want to scale. But there is a scale bit now. How does it work in an adult hospital? How does it work with an ambulance service? How does it work with A&E? How does it work with general practice? How does it work in mental health? So on. And so we have some money now from NHS England to basically try and do this in the London region. And we're not trying to scale and sell this particular product. We're just trying to demonstrate here are the multiple use cases at pace that you can kind of do with this, with an ultimate aim of potentially having ambient technologies available for the NHS. What we mustn't forget in these setups is which is why I say finance is important. There's a different way to think about this. You have some fixed costs, but as we go forward now, we'll also have other, what we would call revenue costs. So often the problem, particularly in our system, is we're sometimes, or certainly our hospital, we're often capital rich, so I can do that bit easy, but I've got no revenue. So now I've got to find a new payment model. So what have we learned to date? So clearly, the most important thing is just make sure you keep your patients and your families protected and you engage with them. So that's stakeholder piece. And actually, I've focused on patients, but clearly the clinicians as well. This is super, super important. So in fact, we've had to establish a completely separate committee that deals with data partnerships and how we use data, because it doesn't go to R&D, you will not get an answer that you'll be able to take forward because nobody really understands this world, so that's going to be very important. Just as a note on that, I think one of the things that in the session we had before, in 10 years, one of the things that I have noticed in the innovation world is things were probably slightly easier to do 10 years ago because we didn't have any regulation. As we get more regulation, let's not become over-regulated. In one of my worlds, regulation now is so huge, you kind of think, well, I can't do anything anymore, I certainly can't innovate. So I think because we're at that early phase, but we know people have these anxieties, we must make sure that that follows us through. Make sure you have something that guides you. There are lots of documents out there. The NHS has had an AI council for the last 2 years, so there are lots and lots of things out there that you could look at, but these were what we did internally. You have to have a firm data foundation, so we've really focused on data and how you get it out. So when we put in our electronic patient record, we also put in a secure data environment. But what that's enabled us to do is then build on that. So our clinical intelligence research facility is now 32 PhDs working with our data to develop AI tools. We can now share data very easily. Again, we've got the governance to do it and the approvals to do it, which is interesting, the more difficult bits, with strategic partners who might want to interact with us. We've now got a lot of operational data. How do we use that data in the hospital, which is our clinical intelligence unit? And now increasingly, how do you use the data for AI? So a firm data platform is very important. You've got to be able to analyze that data. So again, we have this clinical insights unit, and you've got to come up with ways that do it. As in my analogy with a lab, you need to know, I've run an AI ML algorithm today. Did it do what I thought it was supposed to do today? And that's going to need different people to think about it. And then I think importantly, and we've all touched on this, collaboration is super important. And that's all the people in this room, and they're on my second slide, but it's also industry, commercial partners, people who think differently to us, who'll help us on this journey. And quite frankly, people who can pay better than us. So one of my models with Ocado is, you've got people who are well paid there, they are basically a supermarket, they're trying to work out how their chain works from delivery, but they're also, is that a great purpose in life for a young AI analyst? Not completely clear. But actually, if you say you could work with NHS data, Ocado want to interact with us, they will pay somebody a decent rate to work with us for a year. This is great. And that sort of model, I think, is really important. As I've said, the learnings that we've had from Alder Hey, but also through our Children's Hospital Alliance in the UK, Echo clearly, we are part of it, as well as Alder Hey on this Alliance of Centres for AI Medicine, and then various other things. So those partnerships, again, and this sort of meeting are super crucial for taking things forward. So if I looked at that chaos, the thing in the future looks very different, because if you, particularly from an AI perspective, if I bought a bit of software in the past, it probably doesn't change dramatically. My ICT department will manage it, they'll sweat the asset. If I buy an AI algorithm, I've got to monitor it. It could be different tomorrow. And actually, importantly, particularly clinicians, I need them involved in what is right, what is wrong, how is it working. So I do think there is a new way forward for us. Whether you call it AI medicine, whether you call it analytics department, whatever you call it, there is a new thing that we're going to need to do as we begin to embed these things into our hospitals. Thank you very much. Very happy to take questions.
Thank you. So previously we had the panel about the strategy of implementing innovation. Now it's about the implementation. So the panel called The Ultimate Test, Bringing Innovations to Life. And we have 3 people who are more like practically and hands-on involved. So I'd like to invite on stage the 3 speakers. First of all, Pekka Kari, Development Manager in Health at Helsinki University Hospital. Thomas Lobes, social entrepreneur and designer. Besides being an educator, in 2019 he founded Nixie for Children, of which he is the CEO. And we have Dr. Hans-Peter Dauber, a highly respected expert in health technology assessment, best known for founding the German Agency for Health Technology Assessment. And the moderator is going to be Maria Sanchez Amat. She works in EIT Health as Senior Open Innovation and Innovative Procurement Manager.
So, welcome, all of you. Can you hear me? Yeah. And thank you for the invitation and for this great panel. First, before initiating the session, I would like to talk about a project I'm involved with coordinating is San Joan de Déu. We collaborate with Cienciano, Aquas, ECHO, I'm not going to leave anyone, no? And Invenium. So, sorry. So, the project is called Ad for Kids, and the main goal, I'm not going to explain the whole project, but the main goal here is to focus on demand-driven innovation, so really understanding, as we have been talking here before, what is the real need coming from patients, coming from families, coming from hospital needs, and try to drive innovation from the demand. Also, we would like to fast-track the innovation adoption. So innovation is very broad as we talk, and it can be in the processes, in the way we deliver healthcare, but also can entail incorporating technologies, devices, and other ways of managing the hospital. So what we would like is to really pass from the lab to the hands of the patient and really make an impact and transform the way the healthcare is delivered. And to do that, we are developing and we are working in creating training programs, because we have learned it's very important to train all stakeholders, innovators, but also clinicians and innovation units and other parts of the hospital and healthcare system. But we also want to do accelerator programs. And we want to activate or create working groups that could be active and could be continue or could be living after the length of the project and continuously start thinking on new challenges and new ways to overcome these challenges. So you are all invited to participate in these working groups, and we would like to last for long and create this community and this collaboration that we have been talking. And finally, we have a big goal, and it's a bit scary, but I think with all of you here, we can make it, is to create a European action plan that we want to be actionable for fast-track innovation adoption in Europe. And we have been doing many interviews, and we are really looking forward to create an action plan and actionate and convince European Commission and other founders to support us in activating it. And then I don't want to extend more, so I would like to introduce this nice panel. We are going to talk about this, how we can adopt innovation using different instruments, and maybe we need to create new ones. And first, I would like to give the floor to you, Hans, to introduce yourself and the rest of the panelists.
Yeah, as I've heard, I'm trained as a cardiac surgeon, and then I moved to the Federal Ministry of Health, and I have to set up a new agency for HTA together with a colleague who is now in the Reimbursement Institute, IQWIC, and we did it in 2000. Even if we are gender biased here, by all the men, the knowledge I have is coming from a woman, and so it's what we have introduced from other countries, and yeah, it took something what we discussed before, and what the speaker just before said. At this time we had no regulation on anything, and it was easy to share. So when I wrote something in English, I sent it to Southampton, and then it could easily be implemented as good English and not as bad English as I had it at this time. So cooperation, collaboration is what I like in the European area. Thank you.
Thank you, Hans. So Tomás.
My name is Tomás, and I come from the design world, so I'm kind of new in the health industry, and I'm loving it. I started Dixie for Children, which is a company where we create preparation kits for children in order to make sure that they understand everything that's going to happen when they go to the hospital. And this was my final research project in the university when I was studying. So we are 5 years in, we are in 26 hospitals now, and we are working with 10 different treatments. And well, this is Nixie, so you can picture her. And yeah, that's pretty much it.
Good morning. So I'm Pekka Kahri. I work in Helsinki University Hospital. I'm a development manager and working closely with our pediatrics department, even though also with some other departments in our hospital. I have quite a long experience in working with innovation, also from the innovation funding side. So in my previous roles, so tried to stimulate how the demand-driven or demand-led innovation could be implemented, and I have to say that it's been very long journey in this context. There's been a lot of discussion about this, but I think that there are still things that we need to do. Currently, I'm working a lot with data and digital services, also in the context of ECHO, European Children's Hospital Organization. So it's great to be here today.
Okay, thank you, Pekka. So I will start with you. So, like being now in a hospital, what do you think is the biggest challenge that hospitals have when incorporate or adopt new technologies or innovative solutions? How you will describe this panorama?
I think that if you think about new and innovative, it involves risk, and hospitals in their basic DNA, they are against that type of activity. Typically risk averse, so not really willing to take risk. At least in public healthcare organizations, so the procurement processes are relatively formal or very formal, which also lead into that it invites certain types of vendors to propose their solutions. Often they are big established players. It requires that there are already references which you can show, and if you're coming with a new and innovative solution, this is often not the case. The third is that it's so complex. The interdependencies, both in systems, but also the human interdependencies. And innovation means that you need to change something often also in the actual care delivery or the processes, which then comes to very complex things around roles and change management and retraining, and then all that has to be then also communicated that it adds and creates value for patients. So it's extremely complex, and I think these together, they make it highly difficult to go into this space. It's not impossible, but it's really difficult to do.
And particularly in pediatrics, do you think there is something like even more difficult, or is easier in that case? How you see?
It might be in some sense. It might have some easier parts because it's. But it also might be a bit more difficult. Of course, the size of the field that we're talking about is of course it's smaller. It is the role of families and caretakers is much stronger than in adult care, which is of course it can be an asset or easier approach, but it also can be a bit more difficult. But I think that in principle, the challenges are similar.
Okay, thank you very much. So now, Thomas, I will continue with you. So is the other side of the coin, no? How difficult is to you to approach or to integrate your solution or your innovation in a hospital? Which are the challenges you are facing?
Well, it's been a challenge for sure. I mean, it's been 5 years of trying to understand better how the system works and how our solution could fit not only in the day-to-day care, which is what we designed for, but also in the funding system. I think there was really good ideas today on the previous panels, and the main thing that comes to my head when I think of how to make Nixie come into the hospital is we had to change so many times the business model to adapt it, not by the kind of products that we have, which is mainly one product, but to specially adapt it to every different treatment that we have inside the same hospital. We had different business models for different preparation kits for different treatments. And as it's not a clear path into the public healthcare system yet, I think we're doing great steps, but it's not clear. I think this is also a thing that it's not attracting as much talent as we could, as there's people trying to create startups and they are not sure about going to the healthcare system because they are not sure about how are they going to sell, and this is preventing them of finding funds sometimes. So I think that if we have a better, like a more established track on how are we evaluating solutions and what value should we provide, then we could also do our own homework better in finding the good data that the hospital needs in order to decide if they want our solution or not.
Okay, thank you. And this very links with my question to you, Hans. So how a health technology assessment agency can play a role in this field, no? How you can support innovators to understand what they need, and how you can support hospitals to adopt or to be more sure and less risk adverse on their innovation adoption.
How many hours do we have? The issue is, first of all, you have to see that we have a problem, who is responsible for what. If hospitals in Finland are different from the hospitals in Germany, are different from the hospitals in Spain, how they make their procurement. In Germany, for example, your topic would never be within the payment of the healthcare system. It would be the investment of the hospital. Just split it up. So what is very important at the beginning is to make clear what kind of context you are working in. How are the wordings? What do we have to respect in this specific situation? I think this is the first thing you have to do as a startup. As HTA, we are not responsible for a hospital. As HTA, you make a decision on a technology compared to another technology. So it's every time comparing. The comparator can also be nothing. So we do nothing, how is the outcome, and we do something. Are we improving or are we less improving? Unfortunately, nobody is remembering what evidence-based medicine is. Have anybody an idea what evidence-based medicine is? Is it literature search and making meta-analysis? Who's agreeing? If I see anybody? Agreeing? It's wrong. It's totally wrong because David Sackett defined it as Hippocrates 2,000 years ago. Evidence-based medicine is the inclusion of external knowledge in a setting to treat a patient, and this is done by a healthcare professional to adapt it, to make it transferable. And this is what you need in your business, this is what everybody else needs. And everybody thinks now about literature search. So this is failing. So in HTA, we have to see what is working. Can it work in reality? And RCT is never, for example, providing an answer to this. RCT is just saying, might be it could, because at least I found no hurdle that it's not. And then you have to implement something, and then it's not possible. So HTA is just a step to support clinics on the micro level, but also in state affairs, in bigger countries, that you have some kind of support how something could work in a specific setting, which you have to provide, and if you do not do this, then it will not work. So this is what we are offering, and then it's going to decision makers, because HTA is not a group of decision makers. We are collecting information and providing it to those people who then have the chance to decide about it on the best available knowledge to their mindset. Yeah?
No, this is very interesting because it leads to one of these mechanisms that we can become an early adopter and implement this solution while we are doing this evaluation, but gathering other type of data that allow us to decide if we can continue or procure and incorporate this technology and become a standard of care, that will be a full adoption of the innovation. But then, Pekka, I have a question for you. So when you I don't know if you have experienced the procuring of innovation, but what is integrating this technology? What is from your perspective, how effective is that? How you do that? How you procure the innovation and how you can incorporate it and implement these solutions?
Many of the innovative things, they come somehow from research projects or innovation projects which they think too late about the problem or the challenge of how to make the results then useful and deploy them in a hospital setting. So I think that this is one of the challenges, and in one hand it's also quite, in a way, understandable, because if you start early talking with the procurement people, they will exhaust you with the explanation of their current procedures and standard procedures. And I think that little bit maybe opposing to what Hans you said about that it's very different. For example, procurement processes in principle, they are relatively alike across Europe. It's either an open tender, it's a negotiated tender, or it can be a dynamic procurement system. And then there are these innovative procurement processes. The thing is that it's often seen that innovative procurement is something that you do with special innovative procurement processes. But that need not be the case. You could add innovative elements into your very standard tenders, and a very low threshold way to do that is to introduce an innovative option, so that tenderers, they can provide an optional setting which can be something that is not in the same level of maturity, add-on services which could be then considered. From the innovators' perspective and the research projects' perspective, which are working with new things, I think this challenge of thinking early it comes on several fronts. You should think early also about your building your evidence and going to certification if you need, and so on. And this is often contrary to the innovator mindset, because innovators are really. So how do you combine these two? And I think that team diversity is one of the things that you need. You need different types of personalities who are involved in this in order to be able to act with the fast pace of an innovator, but then also in your team somebody who is thinking long term. So how do we build our process such that when the window for really of opportunity of proposing it to a big customer opens up, so how we are ready? Because timing is also a crucial factor. A hospital might have a window of opportunity like a new hospital building. All of a sudden there are lots of opportunities, but for the next 15 years there is very dry season for any innovators to propose anything.
Okay, thank you. And again, Thomas, how do you, when you experience or facing or seeing your product being procured in a public procurement process, what do you need, or what do you believe it could be the support you will need, or you know how to navigate very easily?
What we experience is something similar to what Ian explained about the squishing method. It's something like this. We usually find champions inside the hospital, which are usually the doctors or the frontline who are going to be using our solution which, by the way, is a virtual reality training kit that also has a plush toy and stuff. So it's a training kit for the whole family. And the doctors can clearly see the value of it, but most of the times they are not trained on how to implement innovation, so they don't know who to call inside the hospital, and then it becomes like a research process inside the hospital. And, okay, who should we call innovation, or it's patient experience, or sometimes it's not clear, and this leads into delays on the trying of the products. And then we end up doing a research process for every hospital that we go in. And we managed to sell directly to public hospitals mainly, and also private ones in different ways, but we haven't managed yet to do like a region-wide deal that comes from the top. And this is where we're facing the most challenges, because we don't know what's the person to call to. And this is something that I think that all the innovators in the startup field some kind of feel. There's different products, and every product has a different protocol on how it could be implemented, but there's still a lot of question marks.
So,
at least from a design perspective, not knowing a lot about the healthcare system and training on how to sell something in the healthcare system. Yeah.
Yes, and I guess in Europe it will be even more difficult now, and different ways to approach. So I understand from your explanation that at hospital level you can manage, or you found a way to manage, but at health system level, like to scale it up and deploy in the region or in the country, is where you are facing more problems.
Nowadays, yes. And it's also what Hans-Peter said. It depends also on the country. Like maybe in Germany they have the Riga system and reimbursement is way clearer. In Spain, I don't know. It's not yet there.
Okay. So Hans, can you give us some light on how this public procurement currently facilitate or hinder the incorporation of this technology?
First of all, you should go to Aquas in Spain, and then they will do it. Secondly, remember COVID. There we had been able to do something in an extremely short time period. So the problem very often is, if you do not have a clear unmet needs and you cannot prioritize it, you will take it, I will check it tomorrow, I will check it next week, I will check it next year. Is it really needed? Is very important, and you have to underline this for the prioritization process. If you go for prioritization processes, it's also very interesting that who is aware of pre-commercial procurement in Europe? Anybody heard about it? So before you start to develop your product, you can even go and we tested it, or we are testing it in Europe, that you have, first of all, you have the unmet needs, you highlight it, and then companies can apply to get even funding to go through different steps to the market, so that they can even sell the product before they are really on the market. So we do have different kind of issues, solutions for specific issues. What we do not have is a common knowledge. So the problem is for startups, where to find the right knowledge, what I have to do now. Knowledge management is our biggest issue. So you have sometimes to find the right people at the right time who can help you, and this coincidence is, for me, is the hurdle. If you have people in the hospitals, like in UK, they have to go to him. But I have also people in UK who are member of our network in Newcastle. It's fantastic about AI, what we just have heard. They develop AI solutions, but the people in the same institution using AI should use it, they deny it because they do not trust it. So if this is done in the same institution, how should I now, as an institution in another hospital like in Helsinki, use the AI, develop and trust the development of the AI thing? So it means you have to get aware what to do when, and to raise the topic, as you said it at the beginning, demands. Where is the demand? And is the demand then also has an impact on the outcome? So it's nice to have, but do we need it? And if you can make this in a right way, visible for the outer area, then it's also easier to go to procurement offices, to go to public institutions who are financing on a sustainability approach. And then you will find more open doors and open-minded. And then you have to go back to the hospitals again. And then you have to have people who are listening to you. And this is difficult because they have never time. So when you come to the hospital where I was, it was better to bring some cake with you. Then at least I can eat the cake while you're telling me something. Yeah? So this is, yeah, we are human beings. Yeah? And research in university in Germany is done after your normal working time. Yeah? So this you have to keep in mind when you go to these people. And the people who are working, they have to get open-minded for innovations. And then they can do something, and then they can help you. It's not only an innovation institute. You need also open-minded people in daily affairs.
Thank you. And what about the cross-border procurement? Can you give us some insights from your perspective?
We have not a European healthcare system. So being part of the Ministry of Health of Germany, we are responsible in Germany for our healthcare system. But this is the same in Denmark, in Spain, not in Spain. In Spain it is the region, the state of yes, Catalonia and whatever, okay? Cross-border is problematic if you go, for example, to Italy. They have also their regions. If you go to another area, it's immediately a problem. If you go in Spain from Andalusia to the Basque, you are crossing borders. The problem in Spain they have solved, so people can go wherever they want. Even if the service is different, they can get all service. I'm living in an area in Germany which is close to Belgium and Netherlands, so it's more or less one region. We have one dialect. Only the French fries are different, so that's why we have to switch all the time. The area there means a person from Belgium can come to Germany. If we want to treat them, then we have to get an official permission by the Belgium system, and then we can do it. I once had a colleague from Maastricht, which is a Dutch city, and she got no treatment in the Netherlands. So I told her, please come to me and visit me, and then all of a sudden she has an emergency case, and then immediately I got via fax permission from Netherlands that we can treat her. Because it was emergency, it was easy. If I would have done it in a regular way, it would have been an enormous amount of paperwork. In procurement, it doesn't matter. So in principle, we have, procurement is something which is European market. So if there's something agreed in Portugal, I can use it in Germany. So this is not the problem. I just have to prove that it's according to the German health system. If not, I can use it in the German health service, but not on a public and a private way. In hospital, I can do whatever I want. So the German system is, in hospitals you can do whatever you want because you're reducing the risk. Because in a hospital there are constantly people who are taking care. That's why you can do it. In ambulatory care, you are not allowed to do because very often the patient is at home. So if you now go to this procurement over the border, in principle you have the option, but you have to describe for every country why they should do it. And this you cannot do. It's impossible for him as a small SME because the knowledge he doesn't have. Again, you have to know somebody. Go to her in Denmark and ask her what we can do here in Denmark. Because I think they like it. Yeah? And this is the way how you should go forward. And then you can make selling over the borders. And I mentioned exactly not procurement, but it's selling over the borders to other healthcare systems.
So, okay, thank you. I'm going to ask Becca, so do you think for pediatrics, because I'm thinking about the small market that we are hearing a lot, no? How this cross-border public procurement in different ways, in a pre-commercial way or in a PPI way, could solve, no, this this small market kind of issue, or at least the pathway to go to one market, then the other one, then the other one. So do you see that as a way or that is worth trying? Or
I think it's an opportunity, and even if not talking about innovative procurement, so some sort of generating a larger market with joint procurement activities or some sort of joint advocacy towards critical topics in availability of pediatric devices or even some consumables or materials for pediatrics, that could be an opportunity. I think that the innovative procurement could then be maybe experimented and developed there on the side, but I think that even the lower hanging fruit might be just to join forces on some of the critical topics that are seen in the European market for pediatrics and start the collaboration based on that. It's challenging already in a nation state level, so but there are ways that hospitals, for example in Finland, can jointly procure stuff, so it's not impossible. But I think that the need and the added value has to be really clear, and it might be that some pressing actual problem with availability of some devices or some materials could be even a low-hanging fruit.
Okay, thank you. And now we are going to move a little bit from more the patient involvement in this decision making or in this demand-driven innovation, because I would like to know, Hans, from your experience and your background, how well patients and families are represented in and integrating in these decision-making processes, evaluation of technologies, or even in the design. So what is your perspective?
From the healthcare system, when we implemented the HTA, we included also patient groups. In fact, we had the problem, what are the good patient groups and what are the bad patient groups? So in the Ministry of Health, we make a list of certified organizations who has been proven not to be sponsored by industry by itself. So the most worst patient group I had was the patient group of comatose patients. So I was very curious to see how they are talking to each other. And it was then quite a lot of industry behind it. The integration of patient organization must be very careful. As there's a myth about the small market for pediatrics, we have also orphan diseases, which are even smaller. So this is in principle not a problem of a small market. But you have every time a specific group for a specific disease. And it's our task as a healthcare system to harmonize it a little bit, to make, to see that everybody is treated in a fair way. So not only those who are noisy have to get everything, and those who are quiet have to get nothing. So you have to harmonize it. That's why I like to include patients' organizations, families, to see how. I'm a medical doctor, so I have to see what's beyond clinical. What is going on at home? How we can support it, makes it sense. For this, you have to include these people. That's fair. But then, when the decision is coming up, they have to go out, because they have a conflict of interest. And in these cases, you cannot put them into the decision. It's also unfair, because of what should they say? They want to take care of their people, and that's why it's fair to get it out, but to get their knowledge into your decision process, requirements, demands, that you can see whether something could work on it, make it a sustainable approach when you decide something on this. So in this way, split it up, incorporate the knowledge, exclude them from decision.
Okay, and Thomas, in your development in NICSI, how you incorporate patients, at what level or at what point of your development?
We actually need them in the whole process. Like most of the times as a CEO, you are required to lay out like a strategy for your startup and where you're going, what's the strategy. And most of the times the reality is that the needs and the ideas on how to better use our product come from the patients and the families and the people inside the hospital. So what we do is we just incorporate families and children that have just recently lived the treatments that we are going to be working on and the ones that already have passed it a few years because they have different experiences on how they remember the treatment and back at the time. And then we create the product, and then when we test it, we make sure that we gather the right feedback from the families that receive it for the first time without knowing anything about the product. And yeah, that's how we do it.
So in the design and also in the different iterations of the product, you also incorporate, or in evaluating the product, or you don't?
Yeah, the good thing about our product is that it's not really high-tech intensive. We use cardboard headsets, and the content that we do is the main part of the product. So it's really easy for us to make small changes. Even with the plush toy that we have for some treatments, we can keep adding things like, oh, we need fingers for the plush toy. So that's the last version with fingers. So we just keep tweaking the product bit by bit, focus on the feedback that they give us.
Super. And finally, Pekka, so how hospitals ensure that patients' voice and needs and demands are part of the innovation and decision-making processes, or evaluating the innovations?
I think it's a very generic thing that if a hospital or healthcare organization wants to mirror itself and mirror its activities, has to be throughout the culture. So getting both quantitative and qualitative feedback from patients on all activities. So in normal care delivery and also on the innovative stuff, which you can't think of that innovation would be somehow separated or different or special about that. But the healthcare provider has to be really truly interested in asking systematically and then also reacting or processing the feedback that is coming. Otherwise, it makes no sense. And innovation is a small part of that. And if it's not the culture of the organization, it risks not to happen even with innovative new things. The representation problem is always there, but there are ways to engage, and it's then also about the methods and the assessment of those who are developing it, how these are taken into consideration. And sometimes we have to remember the quote from Steve Jobs. Customers don't know what they want, so sometimes also to think about how to bring something very radical, but then again get feedback and get the opinion.
Okay, and thinking about pediatrics, how different is this community? How you receive this feedback? Because I think it could be different, no, from parents to kids to. So how you do that, or in practical in pediatrics?
I think that this aspect of parents and caretakers is really important, and pediatric departments are good at doing that. The difficulties might come if you have to engage with the school or the daycare or some informal carers, because they are somehow at the fringes of this. But I think that it's pretty well handled, and it is part of a DNA in pediatric hospitals that families and caretakers are taken involved. The difficulty is that if you have to reach out to schools or to daycare, for example, on mental health issues or behavioral neurodevelopmental things, where this is really important to get their feedback, and I think there's some work to be done still, but.
Yeah. Thank you. Yes.
And I think that we have a really cool thing about children is that they are like the most honest people that we can trust and rely on. So if you ask a children, okay, do you like this? And it's like, no, this is not what I want. I want this. And yeah, and you get really honest feedback really quick.
This is great. Thank you. And I also like that you when you ask for feedback, that you really care and incorporate and make them feel that they are listened. No, somehow this is also important. To mention. So I would like to, we don't have much time, but I would like to open the floor for questions, if you have any questions in the audience. Yes?
What is different of what you just said about children compared to adults? So you think that children like to be respected?
No, everyone.
Exactly, yeah. In principle, it's just a specific situation, and children you have to treat different than adults, yes. But in principle, Also, I think if I take this puppet and explain somebody how I make the cardiac surgery, they would also be happy. It's just fun. It's joyful. It makes it a little bit less afraid. And in children's area, we have also to face that the parents. I think you mentioned we have to educate them. No, I do not want this, because if I can educate a patient in 10 minutes when I explain something, then I'm afraid that I have not really done my really job, because I have used 10 years of study and 10 years of clinical developments, and 20 years I can explain in 10 minutes. I think this is not possible. But I can help them to get trust, to get confidence, to feel safe, and to make a decision which is surely influenced by me, but on the idea of the patient, what they want to have, what they have to. So I have to talk, and this I have to do in 10 minutes. And parents very often are, today I just got 2 grandchilds, and so I had now this parents approach from my children, one in Denmark, one in Germany, but they are both totally afraid, because they are overwhelmed with topics, and they do not know how to handle it. So I think this is also very important, to help them through the jungle, through the internet. And this is, for me, extremely important, especially in children, because everybody wants to do the best for the children, but they are lost.
Thank you. So questions? Any question?
I've got microphone number 3 on me.
Well, thank you. Yeah, can you hear me? Yeah. Well, thank you for the panel, and I have a kind of tricky question, and probably since everyone comes from a very different place, no, the answer could be very different. But if you could think about the most important thing that could be improved to facilitate the adoption of solutions, not the end of the innovation channel, no, we have been doing a lot of efforts into identifying needs, developing prototypes, validating clinical studies, raising money, going through regulatory, but at the end, the adoption fails. So everything that you did before all the effort, it's kind of, no. So if you could think about one thing that you know that if you put a lot of effort on that, you know that the adoption will improve, what would that be?
Who wants to start?
Put it to the guideline. National guidelines, put it in, and then you raise awareness of this. This is the most important topic, because if you are not aware, you can wait like in treatments for 10 years till the clinicians get aware of what's going on.
Well, I think as a startup perspective, you are creating things, and most of the startups fail because of product market fit. So it's make sure that what you're doing is going to be easily implemented, not to go through the hurdles of doing everything, funding, and then when you have it ready, implement it and see it not work is the most painful thing that can happen to you. So make sure that you make this part of the design process in the beginning.
A little bit building on that, I think that the need to communicate what is the value all the time, throughout the entire process, and also thinking about your audience, who you're talking, whether it's the families, whether it's the healthcare professional, whether it's the middle managers who, as we heard, have to be squeezed. So how to communicate that what is the value of the approach? So I think that's one thing that could help, and I think that it is innovators and people who are working with their own baby a lot. So might take things for granted that everybody understands. So really communicating what is the added value for me and for the audience that you're talking to.
Thank you. I would like to add also, very in line with what you were saying, to me is collaborate early as possible, and get all the perspectives, and to really make sure that there is a problem. Because if there is a problem, you will need to solve it and demonstrate, and also start gathering evidence that demonstrate that you can solve this problem, but the problem in a holistic way for the system, for the parents, for the kid, for the healthcare providers, the IT department and check, 360 everything that entails to adopt your innovation. We don't have more time for questions, right?
No, we do not.
Okay. So thank you very much, all of you.
I am sorry I have to stick to a very unforgiving time frame, but there is one very good compromise. Now it is time for lunch, and it is a perfect opportunity for you to catch these 4 people, because I saw at least one hand, but there's probably like 75 mental hands, given that this is also partially a Baltic audience. See you here in 1:15, in 45 minutes.
Runāju? Var dzirdēt labāk? Mēs svētdien negribam būt.
Hi everyone. So it's already 2 minutes past, just like the previous time. Everyone's a little tardy, but I understand hunger has also struck me and I wanted to stay a few minutes longer to chat with people. But on we must go. And this time there are going to be 2 talks about design and 1 talk, a fireside chat, in fact, and then a pitching competition. But before we get there, first things first, design. When we think about design, we always, well, not always, but a lot of the time think about how things are running smoothly for the organization. But do we talk a lot about how it makes us feel? Like, does it make us feel safe? Does it make us feel like the hospital is a good environment? Well, more important for example, me, I felt intimidated by MRI. More important for the kids who are terrified of those. So I'd like to invite on stage 2 speakers, both from Studio H2E, Ingun Ehlere, the founder and creative lead of design, and Ieva Timoshko, multidisciplinary graphic designer.
Thank you. We both are designers, and we will talk about from our point of view, professional point of view, and we talk to share to you our experience to designing wayfinding and environmental design for children hospital, a mental health center. And why? The physical environment plays a huge role to the treatment of mental issues, and that's what we want to share with you is how design can serve as tool for this mental healing. And our task was to add an additional layer to interior, but create architect studio NAMS to add the wayfinding system, to add environmental graphic, to add interactivities and interior elements, and to create like inclusive environment for patients in a holistic way. What we do in this process takes 2 years, and closely with the hospital team, we go step by step through research, through established design strategy, through storytelling, through defining this wayfinding concept, to make some furniture drawings and interactive plays and elements. and at the end to implement all of this. And yeah, safe and inclusive environment was our goal, and the tool was design. And why? Not why, but as a method we use experience design. And what is experience design? Experience design connect peoples to place. And in this way, in the three levels. The first, basement level, we provide functionality, like clear directions, clear space numbers. The second level, we added value, like tone of voice, like signs on the doors, not the monologue, but like dialogue. The third level, meaning. The meaning, like purposeful interactions that enriched humans. And but why we need design in the hospitals? Because Latvia is a small country, a beautiful country, and we don't have
the hospitals are actually one of the most expensive buildings to build, to maintain, and therefore we can't afford to have bad design in such an important building.
And that's why we need to try to do the best that we can with design. And what means better design? Better design means a better patient experience. Because design is not about we see. Design is what we feel in the space. And shaping the ways what the patient feels it's this space at ease, in control, in comfort, in secure. And user focus was in our center, because this mental hospital is for children with a big difference of age from 2 till 18, and there is also many user groups. For example, their parents, grandparents, and hospital staff, and all these users need different needs, and they have different visual perceptions. We have very inspiring collaboration with hospital, all of this hospital leads and Nikita Bezborodov teams, and we have many consultations with autism specialists and workshops with psychiatric residents. We read literature, not just our design literature in this field, but what recommend Nikita Bezborodov's. And at the end, here is some aspects that we take. For example, green color from the nature, another aspect. The viewpoint of the child for visual communication. Another, to create different zoning for introvert children and to provide opportunity to socialize. And all these aspects like sensory experience, this non-reflective materials, color system, visual storytelling was very important to define this design concept. You already know this house theory and butterfly effect concept, that each detail is very important. And that's why in this research process we find this resume for our decision, that every detail is important and that is huge consequences. Concept about butterflies came from Nikita Bezborodov, because butterfly is the mental like symbol for mental health, yeah. And that's why we put this butterfly in the center, but we use not Australian or African butterflies, but native butterflies from Latvia. In Latvia, we have many species from butterfly and 7 families of butterflies. And each family we use for different room groups. Another design decision, especially for this digital era, we decided to not use photographs, but use hand drawings, to stop time in this drawing and feel this touch of pencil on the paper. And here is the process in our studio. We draw all these families, and here is this end process, and yeah. And the second element of environmental graphics was watercolor, to save place for imagination for everybody. And we did many tests, what we discussed with hospital team and patients. It was a very long process to come for, here is one page from design project of what is base for our solutions, and plan, for example, for second floor, when each room group, it's depicted for each
a different butterfly for each section is assigned. Just to there's no randomness. There is allocation also for place making and recognition where you are in the hospital. It helps the color and the type of butterfly.
This is the result for second floor, and for us it's very important to improve that. Good environment helps to destigmatize mental health, and invite all to feel free as butterfly, and imagine what everyone's want in this watercolor drawing, because respect for diversity is it's the basement for sustainability. And for next process, I give.
Thank you. Yeah. So the concept for wayfind design actually strives from the overall design strategy for the outdoor and indoor wayfinding design throughout the hospital territory. And it's based on the modular principle, which is very practical in a sense that it's easy to clean, easy to change if needed, and also it's cost effective to produce. As you can see, there's one bit is relatively larger than the other. We use green color throughout this building because, again, it strives from the overall concept that each building in the children's hospital territory has an assigned color. In this instance, it's green, so we use it throughout. We make sure that the wayfinding, the navigation signs are in height for children, not for next Porzingis, which is good to have tall people, but this is for children, and we need to remember that when we do our work. One vertical, standing standpoint is positioned right in front when you enter the building, and that's done purposefully to answer this immediate frustration that one might have. What's on this building? What can I find in there? So 3 levels, what's on each level, and give you immediate points where you need to go, such as self-check-in, check-in, and obviously the important parts of the hospital as toilet and wardrobe. A unique icon system is created, and it also helps for the overall system that you recognize where they are. It's done in a minimal style to convey the message as simple as possible. Not too many details, not to complicate it visually. One of the research findings that we had and discussed, both with the hospital and ourselves, there is a lot of warning signs in the hospital, things that you should not do. And although those are very important messages that need to be communicated to the patients and their families, but we can emphasize, all of us, that nobody likes to be told of what not to do. And therefore, we put emphasis on the positive encouragements, what you should do. And a system of various types of signs were created. We tested ourselves, sent to the hospital. Hospital then tested them with audience, with patients, and then came back with the things that they felt were not understandable. So we tried to be as clear as possible. And this is how it's placed, again, very organically and very cost-effective way in front of the door for the inside going into the ward or just before entering a doctor's room. Language is very important, and also again emphasizing with people, patients standing outside of the door, being in an unknown space and not knowing the rules. Should I knock on the door? Should I wait? It creates the frustration that we can avoid with wayfinding signage. And therefore, in the shape of the speech bubble, there's little stickers outside every door of doctors' rooms that says, "Wait, you will be called," and immediately that question is answered before it arises. And here, this is a structured photo of how it all ties together. So we have large, clear room numbers, so you don't have to look in these small numbers, where are they, what is the room that you are looking for. Important part is these monitors right outside the appointment rooms with portraits of doctors and also photographies of the interior that inside, kind of to prepare the patient before they go in and to ease their experience of what's to come. We believe that wayfinding design is not just about placing numbers on the doors, navigating throughout the building, which is very important, but also to give a sense of place, familiarity when you are there. And as even such a functional space as staircases, which are normally very plain and there's nothing left there because everything is focused on the actual wards or the building itself, we decided that the butterfly is following you. It guides you through from one level to another through this dotted line. And process is a very important part of our job, just to check for ourselves, is the material going back to our initial research phase? Is it non-reflective? Does it help the user? Is it visible? But we also did ask the doctors, the hospital team to come and test with us, because obviously they are the people that will work there. They will know how the building is operated, and they can guide us where the signage is maybe misleading or some adjustments might be needed. Another part of our task was to create some interior elements, such as furniture. And as Ingunn already mentioned, there's two types of groups that we kind of divided. And one is these young teenagers in mind, also called the hoodie generation. And therefore the chairs, like hoodies, were placed in this one zone where a kid can kind of lay in and hide oneself from the distractions around. In contrary, the other is very open plan, and it was designed by our own team for this particular space in level 1 waiting area. Fluid lines, easy to change if needed. Yeah, and that's a place for the patients to wait and to socialize or to observe the space. Just to add an extra layer for this space and being in the hospital, we created some engaging elements to ease the patient while they're waiting. One of them was this projection video. We used this beautiful wooden wall where you can just sit on the seating area and just watch butterflies slowly flying around. Another one with younger kids in mind, there's this touch screen where one can choose one of 3 games. They're all related to the theme of butterflies and helping the butterflies either to draw their wings or to put it together from being broken or to bring it to a flower. And like a cherry on a cake is another solution for waiting. And as we all know, in a digital era, if you haven't taken a photo where you are, this being Instagrammable, it's one of them. The screen where you stand in front of it, like in a mirror, and it scans your body, and you get some wings attached to you, and it immediately kind of elevates everybody, even adults that look in front of themselves. And if the previous ones were visual engagement, then this was based on sound. So we placed also in some waiting areas sound showers, where at the moment you can just sit and listen to nature, but in long term you can change it, the hospital can change it to listen, for example, poems or stories.
Especially for COVID time, yeah.
Yeah, so there's no touch. Sitting, and in the end we want to share you the video, of short video, but if you haven't been there, just to get a sense of what it's like. But the video is gone. It's coming. Okay. So to end our little presentation, we believe that design is experience, and the hospital is definitely a place where we need positive experience. And we very much want to thank the Children's Hospital of Latvia for the experience of working with you, and we've been very happy and lucky to have this wonderful collaboration. Thank you.
Thank you.
All right, now to look at design from a slightly different perspective, this time from Biodesign. So this speech is called, this keynote is called Innovating Pediatric Care with Biodesign by Sis Zoffman-Glud of the Biomedical Design, the Biomedical Design Novo Nordisk Foundation Fellowship Program Lead. Those are the proper accents.
Yes, and yes, thank you very much, and thank you for the invitation to come here and talk about biodesign or biomedical design as a way to go about innovation. And you heard this morning, Vals, he said that the only thing that's never going to go away is the unmet need of patients and healthcare providers. So, and I can very much agree to that point of view. There will always, no matter how much we develop and invent, there will always be new unmet needs to deal with. So biomedical design, and you heard this morning also, the Stanford Biodesign program mentioned, and that's what this is. It's about innovating, starting with the need and not the idea. Yeah, so I'll start out by very quickly just explain a little bit about what biomedical design is, and then go into our experience of doing innovation in a pediatrics department in Denmark. So biomedical design is a educational training program for young professionals who have their core skill in one discipline. And it's a 10-month full-time training program giving a sort of a full cycle of innovation experience. And we provide a monthly grant to cover living expenses because the participants or the innovation fellows, they are people who leave their jobs to join this program. We take in 16 fellows a year, and it's an international program, so we also take people in who don't speak Danish. At least 3 years of work experience. I would say the average age of our participants is 38, so they actually have a lot of experience. And then we join multiple disciplines into this program, because what is important for innovation, and particularly if you want to sort of have holistic innovation, you need many disciplines together in order to come up with really inventive new solutions. Yeah, and the program itself is, as I've already mentioned a bit about, it's needs driven, meaning that we don't start out with a good idea. That's actually the smallest part of innovation. That's the idea. The biggest part of it is actually to understand what is the problem and really get a deep understanding of that. So in order to train our fellows in that, we immerse them into a clinical setting. We collaborate with hospitals all around Denmark to host our innovation fellows. And when they have spotted problems, then we'll learn them how to analyze these. And some of these problems then turn out to be really unmet needs that are worth pursuing with an innovation approach. Only after that, we then begin to ideate solutions, and also again, constantly iterative processes of going back and forth with the different stakeholders to make sure that also the ideas are appropriate way of solving that unmet need. And lastly, we focus on, develop the concept, but also develop the strategies for implementing these ideas. And that can also be a killer for some ideas, because there are both financial and regulatory constraints on some things. And we actually try to incorporate that early into the program, or into the ideation phase, to avoid that ideas have to stop here in the end of the program. So in 2021, we collaborated with Aalborg University Hospital and their pediatric department. And I can say for having such a collaboration, we need great engagement and championship and we had that from the chief physician and the section head nurses of both the outpatient clinic, the ward, and the neonatal department. And then we have, as we have also heard this morning, we need the top and we need the floor people to squeeze the middle. And so what is really critical for such a collaboration is to have really good single point of contacts on the floor who can help our innovation fellows to have a good experience in the department and having access to actually see all the stuff that is not working. So they spent 8 weeks full time in the clinic to shadow the clinical work, and based on that, they, as I said, they identify various problems, and gradually that is turned into a number of unmet needs. So when we want to describe the unmet needs, we also want to know what's the clinical impact, what's the clinical outcome that we need to achieve by any solution to that unmet need. And therefore, when we define the unmet needs, we've defined them in the way where we try to describe a need statement that also pinpoints who's the target population and what's the clinical outcome to achieve. And these need statements, they are, in a presentation setting like this, a bit complicated to understand. So on the next slide, I'm going to, just to give you some impressions of what are the problems that they found. I've sort of simplified these need statements a bit, but it'll give you a hint at least. So one of the needs was that harmful light and noise among preterms in the neonatal intensive care is very harmful and stressful for the development of the neonatals. So clearly there's a need to reduce that stress among neonates. What our fellows saw in the clinic was that the healthcare professionals, they did all sorts of workarounds to try and reduce light and noise. And there are commercial solutions on the market, but they are not proper in order to actually meet this need. So that was one of the needs. Then they also discovered a way to ensure that neonates, they maintain their body temperature when they are moved from the labor room to the intensive care unit. Also, again here, the healthcare staff had invented all sorts of workarounds. None of them really very practical, but there was a need to actually do that. Another need was that they identified or saw that many kids kept coming back for consultations around having problems with constipation. And so they thought, okay, there is really a need here to have some better solutions to avoid that these kids progress into chronic constipations. And what we always, and I have like a side story here to tell, what we ask our fellows to do and care about is to also validate whether the needs that they see in Denmark are important outside Denmark also. Because if they want to solve the needs with technology, it has to have a commercial potential, and that means it has to be needs outside of Denmark too. And it was actually interesting that they discovered that outside of Denmark, constipation and chronic constipation among kids is actually not a very big problem. So I don't know what we do in Denmark to our kids, but there are today more and more pregnancies that go over time, and that causes a high risk for the fetuses. So, but at the same time, good clinical practice is also to try and reduce the number of pregnancies that are then put into labor induction. And so there's a need for a better way to monitor late-term pregnancies in order to reduce labor induction rates and to prevent the hypoxic brain injuries and stillbirths. That was another need. And then the final need for which I'm going to show the end result is a better way to improve invasive tube management in intubated neonatal patients, to reduce the risk of unplanned extubation episodes occurring out of the incubator with 75%. So there is this practice that it's very important for the neonatals to actually experience skin-to-skin contact with their parents. But every time you want to achieve that, you also put the child at risk for tube displacement. And so there was a clear need for solving that. And so when they first identified the issue, the process was then to actually understand it better and have multiple dialogues with the healthcare staff around that to understand it in depth. And also they conducted market analysis, and the health economic insights really changed the scope towards the tube displacement, because they discovered that it's so harmful, and also every tube displacement causes 14 to an extension of the length of stay in the department with 14 days. So that's a lot for every tube displacement, which is the most happens a lot of the times. So in terms of iteration, the important part here, and we had heard about design thinking before, it's actually what we're doing here, coming in with the ugly prototypes, playing around with it, engage the healthcare professional in it in order to get feedback early on simple parts of a potential solution. And that really advances gradually by doing this many, many times. Gradually, you come down to a concept that will actually solve multiple issues of the need. So today, I'll just skip this. The solution looks like something a bit like this. It's not the final solution because I'm not allowed to show that. But the whole concept ended up being a startup called Neocare Nordic, and they are developing this product called Carefold. That is, the child can lie on this when in the incubator, and the sides can be folded up to actually protect the child and make it more stable within the incubator also. And then it's an easy way to actually move the child. Now, there are probably maybe some specialists in the room who then say, "Oh, that is that's going against our NEEDCAP guidelines." And really, that's one of the recommendations here. Try to stay open because maybe the technology is not ending up going to be against the guidelines, but is maybe enhancing it in the end. I can recommend to invite the developers in, because the solution that they have built today is really leaning on the input from the clinical staff in the neonatal intensive care unit. And speaking of not having venture capital for solutions in the pediatric area, Neocare Nordic have actually succeeded in attracting venture capital, so they are among one of these 1.5%. Some takeaways from a program management point of view in terms of doing innovation in the pediatric, I will say the lack of research in pediatric diseases is a main barrier, in my opinion, towards creating more innovation in the area. So it's great that you all here gather around innovation, but don't forget that the research is actually the fundament for being able to pinpoint what are the clinical outcomes that we should aim for and that the solutions should demonstrate before they can be implemented. So, because if you can't make the evidence study, can you then make the solution? And we need research, fundamental research, applied research, translational research to pinpoint where are those clinical endpoints that we have to aim for. We've heard already today the regulatory and the commercial market barriers, and I'm happy to hear and see that there's actually joint forces around trying to resolve these issues. But until that is done, then start with what is possible. Maybe some of the technical solutions that you want to build don't necessarily need to go through a commercial pathway, but can be established through public-private partnerships. And then just always remember that any solution has to be desired, it has to be feasible, and it has to be viable. If you keep those three words in mind, then you are on a good way to succeed with your innovation. Thank you.
All right, your timing is impeccable. Now it is time for a fireside chat, and this one, the organizers told me that the two speakers that are going to be here, they were led into Google Meet or something like a conference call, and they were already getting at it, and then the organizer said, nope, you're no longer allowed to talk to each other, just so to keep this conversation as authentic as it possible. So it's a fireside chat about the journey of an innovator. On the one hand, we have Lina Jankauskaite, a professor, principal investigator, educator at the Lithuanian University of Life Sciences, as well as a pediatric emergency physician at Kaunas Clinical Hospital. So with a physician on the one hand, we have a technology person on the other. Emil Sundyakov, a computer scientist dedicating his skills to solve problems in the healthcare industry. He is an active researcher and a lecturer at the University of Latvia and Riga Technical University. He has a fantastic dog. His name is Ozzy. He likes pets. And Emil is a co-founder of Longenesis. So I'm going to give you...
Yeah, thank you. Thanks a lot.
Okay, it's quite bright here.
Yeah, hi, oh my God.
Actually, we successfully avoided each other, am I right?
Yeah, we tried at least.
Yeah, good,
Yeah.
good to be here.
No, I mean, I was pretty sure that I won't, because otherwise we're gonna talk forever. So, and we're gonna talk forever now. You won't go to the break or something, you know. So, okay.
Good to be here.
Emil, so maybe you introduce yourself a bit, and then I introduce myself a bit, what we do in innovations. Are we familiar with that? Actually, I will tell you one joke about you.
Okay.
You don't know it? So, okay. So I connected to one friend, and she saw that I'm in Riga in this nice innovation event. And she saw that we're gonna have this plenary, or I don't know, this talk to each other. And she said, oh, Emil, I know. He moderated one talk of mine, you know. So you see, networking and teamwork is the dream work. So I mean that connections are very important.
Wow. Okay.
Yeah.
Interesting. So should we run a quick round of intros?
Yes,
yeah?
I guess so.
Yeah, so as the moderator Kasper told, my name is Emil. I'm a computer scientist by education and a bit of a masochist by lifestyle, so I work in healthcare. For more than a decade, worked in research, helped companies, helped hospitals to tell stories based on data. So engage patients, transform data, and so on and so forth. And then we founded a company called Longenesis. So a couple of my colleagues are here as well. And, you know, starting from a whiteboard in one room with a couple of people, now we are the leading digital health startup in Baltics. Yeah, so with around 800,000 patients engaged in multiple countries. But yeah, it was ups and downs, a great roller coaster. If you want to have fun in your life, join healthcare. It's amazing. What about you, Lina?
Yeah, so I think join not only healthcare, but join healthcare and innovations. This combination is killing. So, I mean, I am pediatrician and pediatric emergency physician now. I would identify myself as pediatric pulmonologist maybe a few years later, like back, later, no, not later, but back. So I'm really working in pediatric emergency, but I'm driving as well a center of rare diseases for adults and pediatric. I identify myself as innovator, but maybe you don't know me because I failed more than I succeed. So for this reason, I cannot present you a very successful story about innovations. A few innovations, data-driven, we do have as well, in rare diseases as well, and as we talked to Emil as well on the chat. So I mean, for example, I do have some projects running for innovations, etc., but it's never pediatric driven. It's always from another side, from the broader side, because pediatrics are always like, you know, neglected, or as we already saw in the talks, that it's a small market, it's not important. I was told that it's not important at all, you know, so I mean, that's the problem, yeah. But I do believe in data, and we do a lot of data-driven predictions, prediction modeling, etc., for biomarkers or hospitalization, etc. So, yeah.
Great. So, Lena, you started our talk that, you know, someone you know knows me. So it's small countries here, like Baltics, you know, like we're very close to each other. But, and, you know, it's easy to talk because, you know, we're neighbors, but let's imagine that innovators sitting here or watching us online or outside of this building would like, you know, to work with a hospital, with the institution you work at. How can we, and what are the hurdles? Because there are hurdles there, how to connect these two different islands, because there are often no bridge between them to actually, you know, transfer this people wanting to build or even break something sometimes with the ones who have this need.
Yeah, so, you know, I will tell you that we are a small country, but we are battling inside even between the two hospitals, the two main hospitals we have. So even sometimes we cannot, get a line in our system. Even if we have the same law and every legal system, and we have even electronic data record system. Like I know that some, for example, of European countries do not have it, so it's even harder, because if we want to initiate some project and we do not have any network, so sometimes we write emails, sometimes we go to conferences and get engaged with people. But first we need to have some aligned system. Like for example, for the data, we collect data so scarcely and so randomly. Each and every country has so, different understanding about the data, what to collect, how to register it, how to clean it, etc. The same with my country, for example. We see, I'm working like in rare diseases as well, so we see the necessity. If we have a small pool of patients, so you need data, any type of data. For example, starting from epidemiological data to, I don't know, biobank or something like this, or genetics. But sometimes you do not have a registry for that, or the registry is not aligned. I was giving a talk about the registries and about the data. So, for example, France has more than 150 registries, official registries, like public registries, more or less. In Lithuania, we have one official registry for cancer, I guess, which is not always, supported even. So what about other diseases? I was asking about Duchenne's, for example, muscular atrophy. They said, oh no, we have some Excel file, we fill it in. I mean, what does it mean? What does it tell you? How to collaborate with those people if I have electronic data system? You have Excel, and I ask you to participate in my project, and I know that you're gonna do it manually, all the things. So, and as previously talks were given that every science, every registry is after hours. So who's gonna participate in that? That's, you always need to know the landscape as well. I think if you approach the hospital, you need to know at least the, country's landscape, or to have some acquaintance who could introduce you to that, So what about you? How you approached the hospitals, for example, for the data? I mean, because you already have a startup. Me, I can tell from my perspective, from the clinician perspective, but what about you?
Yeah, let's jump to another island of this innovator. Actually, you should try this chair, it's very comfy. Yeah, so, the funny part of it all, so we've signed the first contract with the local hospital, and it took us exactly the same time we signed the government level project in the Middle East. So imagine, and we know people who work in a hospital, they're friends of ours, we went to the same kindergarten, school, university, etc., etc. I work at the same university these people work, and it took us exactly the same time. And I think it's, from innovators' perspective, it's often a couple of things to consider in terms of, inhaling such innovations. The first and foremost, it's lack of transparency in the process. So I don't know how it's in other regions for sure, but in the regions we work, as well as in the Baltics as an example, we represent, it's mostly, people-based, like person-based. It's not the process. We don't have a very transparent step-by-step process how innovation can be included, validated, or scaled up in the hospital setting, both in adult care as well as the pediatric care. Second of all, oftenly when you come, and it's more of a long-lasting thing, we should change the mindset there, because often when you come to the hospital, on another side, you expect a ready solution that is, fulfilling all your needs, as Yelena outlined. Oh, you need to have interconnection with, I don't know, Lithuanian internal ministry database, then this registry, that registry, and imagine people just starting their own spin-off of the company, come to you with a prototype. They will never reach and they will never read your mind at exactly the first meeting. So you need to have a more agility in the process, because whether you buy a solution, which costs a lot, and there might be no solution on the market, or whether you go hand in hand in this co-design, co-development, co-validation process. And the third thing I think we should consider, and I don't think we utilize this enough, both in pediatric care as well as in the region here, is what Walt said. So there is a stereotype of pediatrics doesn't have too much market value, market shares. And Baltic region is not, you know, a gazillion-dollar industry of healthcare. So we should utilize it as a door opener for the startups. Why not? Because we guys are ready to collaborate with you if you gonna open us the doors for the scalability, because it's all about scalability in the end of the day. If you talk to just IT service provider company, yeah, they will design it for you, you know, for just procurement A, procurement B, procurement C. If you're talking to startups or innovators, design this service or product, it's all about putting your leg inside of the hospital, validating this, and using this as a jump start. And both parties can be getting benefits out of that. You can have, you know, we will not be, you know, a billion-dollar company based in Latvia working with Latvian hospitals or Lithuanian hospitals. There will not be enough money to sustain such revenue streams. But what we can use is use a part of consortiums. Your institution, our institutions, and other institutions are to jumpstart both European founders as well as for non-EU founders, which might be the interesting case as well.
Yeah, I do think as well that it's sometimes even easier when you go systemically and then, you know, downscale to pediatrics, because in majority of the cases, what I saw in the project-wise, in the even administration-wise, I do not talk about the legal things yet, but in majority of the cases they say, oh, come on, so pediatrics take so less of hospital, you know, wards, needs, etc., etc. So we introduced one like small innovation, like logistic innovation. We introduced just some button, which is violet, which is representing rare diseases. And a patient, when he or she comes to emergency department, this button is already, you know, lightened. So it's connected with ORFA code, with specific rare disease code. And actually it's very useful, because then the physician can be, you know, more emphasizing on this patient, more focusing on this patient or needs. But again, it was not introduced to pediatrics. It was first lobbied for the whole hospital, for the whole, yes, definitely. The needs were for the whole population, for adults and pediatric, but more rare diseases are in pediatrics. So it's you know, we were focusing on pediatrics, but in general, we did it for everyone. So, and then we convinced them to do it. Otherwise, they were telling like, you know. So that's the, you know, sometimes the problem, because the money, even the money, there is really funding missing for pediatrics. In majority of the cases, if you stand in line with some other innovations or for the grants or whatever, data-driven, we had some projects with European level. We submitted for the data, for example, for prediction modeling of head trauma outcomes or sepsis or etc. And we were denied, canceled because it was pediatrics. And the players in this game were really strong, like Erasmus MC, you know, and Charité, etc., etc. So it does not even sometimes work. Yeah, some German colleagues are already telling now Charité no. So yeah, so I mean, you know, for us Baltics, I'm sorry, Charité is quite good.
So you're actually quite, you know, a friendly public here, because I went to another conference like 1 hour ago across the river. And there is adult oncology care conference. And, you know, the vibe there is not as positive as here, which is, you know, a very good thing. Let's try to sustain it till the after party, at least.
No, but so, I mean, you know, even if everybody can comment, I guess, or have their own opinion. So.
Sure, but basically, but what I wanted, you know, to put is the seed there is, yes, there is a challenge in funding, but let's look into, you know, various ways how to attract funding. So grants is not only the thing, you know, the only thing that can sustain an innovation per se. Let's talk about the risk capital. If you talk with the VC funds, so the startups who are trying to fundraise, and there are some startups here, they ask you about the scalability, reproducibility, etc., because when we, you know, sold the solution to the first hospital, they said, oh, there's a crazy guys who bought it, like who would buy it once again? Like no one's gonna buy it. You need to showcase how it works, you know. And this is where we can find, you know, added value from for both perspectives. So if you are to approach the innovator stating, okay, I have need A, whatever it is, would like to have visualization of the data of your department, blah, 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 blah. So you define it, but you say clearly what is the process for innovator. Okay, you don't have $1 million to pay them, but you're a member of ECHO, you're a member of this and that consortium, and you will put this flag together with them, if it works. That will be a very interesting thing to invest also both, VC funding-wise, as well as to invest your time-wise and invest also, competence-wise.
Yeah, I do agree, but I mean, I think, I don't know how it's in Latvia, for example. Maybe other countries are more familiar with ECHO or, for example, with the European Academy of Pediatrics or USEM or whatever other organizations. But I think, and on another hand, this is our problem as well as, for example, innovators or clinicians, etc., to promote it more and to educate others, what exists, that is important, that, for example, networking European level is important and the funding comes with that, or you can attract it more. So I do think this is always another thing. What in my country works, I don't know how about you, but in my country works that, for example, if a patient organization or patients are super active, for example, patient parents, there is a lot of funding as well. They can attract as well, because sometimes they are funders, they are innovators as well. So for sure, we were talking during the break that this can lead to some bias as well, because the funds can be very limited. For example, they want them to be used only for that, not that. So this is another thing. So yeah, there are a lot of...
I think there should be a very direct narrative, first and foremost, like in terms of, how we as hospital consortium or public institutions are communicating innovations and helping them out to grow and nurture. Had a funny experience, like we love, to mention Estonians in Latvia at least, But the good thing they're doing, they have a very direct narrative. Like I've met ambassadors of Estonia in Saudi Arabia as an example. He talks about digital health, like bullet point by bullet point. It's crazy. And a couple of years ago, I asked our investment agency to give me some kind of slide deck about Latvia, because I'm going to the conference. I would like to put it there, so to attract some attention. And they gave me a slide where there was some Latvian guy working for Levi's jeans company 100 years ago and this type of jazz. And it's like, no one cares about that, like in healthcare at least. I need to show what we have, like hospital-wise, we're faster, okay, we're small, but we have access to data, we have access to infrastructure, this type of thing. And this type of narrative we should put there and use it as a jumpstart.
Yeah, so I totally agree, because my country is not so far away from Latvia, because
they... Levi's jeans?
Yeah, I mean, no, sometimes they even start from historical facts, or for example, they start how great the hospital is. I mean, okay, very nice, but in general, show me what's your, how you can integrate, and what's your points, what on are you, and I mean, not like, oh, we have this and that, we're built in this year and we are so important and we are the greatest. So sometimes, yeah, every hospital in each and every country is more or less like this, but what are your pros and, and cons, for example. So I agree with that. We have some jokes about Estonians too.
Good. And and the second point I think is what's very important from the innovator perspective, especially in early stages, is that innovation integration is a dialogue. It's not, a mind-reading competition that I put on, and we had this experience, you put the slide and, it's an example from cardiology, and neurologist says like, I don't care, like, okay. And then when you need to read the mind of 100 people in the audience and try to understand how to be completely on the same wave with them. It's okay, but when we talk with institutions and innovators, it should be a dialogue. We should be transparent about the need expectations, understand the clear end goal, end game, and then trying to cut this elephant into pieces.
You need to sell your product. I mean, to lobby it the best. That's, I think, as well. Yeah, because, for example, I totally agree what we had in this process of innovation when we were going through, because we had some ideas, we won with those ideas, whatever, and then we started, to find some investments. And for sure, if you are not, if you don't know whom you for example, are approaching, and the public is very, different, and you are talking only about pediatrics and how it's important, and not, showing different side, then they do not understand. And previously it was told as well that, for example, you need to be clear, because not everybody understands what is catheter, not everybody understands what is pain, not everybody understands this. You need to really talk in simple things, and this dialogue is very important, I agree. And I think another thing about the data, what is important in dialogue, that, for example, everybody would understand that data is everybody's. I mean, that it's very, if some innovations would be built on data and would proceed with data and would be faster, then everybody would benefit. Any type of, for example, epidemiologically, what diseases are there, are they rare, clinical trials can come, for example, or we can fund something more or less, So, I mean, I do believe in data. I don't know how about you. I know that you believe in data because you have data starter. So I do think this is very important as well.
I think there should be, and also, always the pink glasses syndrome for innovators, especially coming from IT sector. And I think we need to then summarize, is that, the more data, the merrier. If you say this to a computer scientist or a data person, he will be amazed. Am I right? Like, the more data, the cooler it is. But then, I've seen innovators coming to the doctor's office and saying, you know what? We've collected 100,000 data points about each one of your patients. Have a look. And you have a 20-minute visit, the follow-up visit with a chronic disease patient as an example. And you will not play Sherlock Holmes, and go through the data rows. And this is what you need to understand, is how to put the right story of the data that you collect at the right point of time. But just maybe summarize, and then I'll shut my mic off and give it to Lina.
No, I will do the same. That the data need to be clean, need to be simplified and adapted to a person set, or to I don't know, any set. For example, what clinicians want. That's very important. Or are you preparing the data for hospitals or for the public, etc. So this needs to be done as well.
Yeah. But just to summarize from my side, so here is once again a very positive crowd. So if there are any innovators, wannabe innovators, use this thing very wisely. Talk to people here, because I think that you can learn quite a lot about both the needs as well as the opportunities here. And once again, comparing this to adult care, I've seen more skepticism in adult care rather than pediatrics, which is a thing we should cultivate. So thanks for coming here once again, and thanks to Lina.
Thanks, Samuel.
So if anything, if you see those two together in a conversation, you're not going to leave it. But we have to now move forwards, and it is the final, well, I guess sort of the penultimate thing in our agenda today. And in a minute, I'll be giving my microphone to someone else. I'm going to give it to Maria. This is the finals of the Hospital Challenge program, I4Kids Europe. And I've got this blurb over here. As part of its strategy to accelerate the introduction of the most innovative solutions for patients in pediatric hospitals in Europe, I4Kids Europe launched the Hospital Challenge Program 2024. This initiative focuses on identifying solutions to key clinical and operational challenges in children's hospitals, personalizing care, optimizing patient flow, enhancing safety, and improving patient and family satisfaction. The European Children's Hospital Organization, or ECHO, already aforementioned, conducted a needs assessment to identify and prioritize the top 3 operational challenges for this call. ECHO's CEOs working together here in Riga participated in a participatory process to select these pressing needs. Helve, which Maria also co-founded, played a key role in facilitating and leading this process, helping to define these critical needs through a participatory approach. The challenges are as follows. Number 1, improving clinical workflows. How can we reduce the amount of time healthcare professionals spend on administrative tasks such as writing patient records, anamneses, and doctor's notes to improve efficiency and allow more focus on patient care? Challenge number 2, high-risk medication monitoring in pediatric patients. How can we ensure that each pediatric patient receives the correct medication in the right dose at the right time and via the appropriate method during hospitalization? Obviously, if it is ingested, then it must be in ice cream form. And challenge number 3, appointment efficiency. How can we reduce the number of no-shows and improve the outcomes for groups affected by healthcare inequalities? The call for solutions invited established companies with advanced technologies, TRL 728, ready for implementation to address these challenges and to be piloted in European pediatric hospitals. So that's what this challenge is about. And to facilitate the pitching competition, I invite on stage the co-founder of Helva, venture partner at Practica Capital, and member of the board at TechChill, Maria Ruchevska.
Thank you. Thank you. Well, hello there. How are you guys feeling? What's the energy level in the room? Okay. I like this enthusiasm, so it's been a long day, right? But the good part is that the most exciting part is yet to start, right? Because everyone's obviously expecting the pitches, right? Okay, so let's start then. So basically, just a bit of a brief of how the process will go. So altogether, for all these 3 challenges, we received around 30 plus applications, of which 6 finalists have been selected. And all of the 6 finalists are obviously here in Riga, ready to deliver the best pitch to date yet. Not only they have already won, actually, because they're here, but also they have received all of their covered expenses for the travel from the Pediatric Innovation Day in Riga, and also the opportunity to pitch to EU Pediatric Innovation Ecosystem. However, only one of these winners will be chosen today. And the winner obviously must excel in idea, quality, innovation, capacity, impact, and also show the team strength, obviously. And the winning solution should be ready to launch in one of the pilot hospitals within a short time frame. I like how enthusiastic we are about the short time frame when it comes to hospitals, right? Everyone's already, yeah, about that short time frame. Not sure, but okay, I love the enthusiasm and the optimism here. So, and about the winning pitch. Do we know what's the prizes here? Do we know what's on the stake? Okay, so the winning team of this startup will receive a 5,000 euro cash prize to start a project within one of the i4Kids Europe hospitals. And of course, also a voucher for consultancy services from the Invenium group. So round of applause to all the project finalists. So we have the startups here. What are we missing in order to really come to the final decision? Any guesses? Yes, the jury. Where's the jury? Raise your hands. Okay, 1, 2, 3, 4, 5, 6. So altogether, we are having 6 jury members. So let me briefly introduce you with our jury. So first off is Mark Ramis. Where are you, Mark? Come on here. The first row seats, obviously, for the jury. You're just hiding back there in the shadow. So Mark here is focused to invest and build companies in the field of children's hospital health and pediatric innovation. He is the CEO at Montana Impact Fund, as well as venture partner at Ship2B Ventures. Mark is passionate about creating novel biomedical ventures. So round of applause for Mark yet again. Next up, we have David Cole coming up. So David here is the CEO of Thinking of Oscar. Thinking of Oscar is dedicated to the memory of Oscar Cole, who died very suddenly in June 2014, aged just 16 months. Thinking of Oscar started off with the aim of supporting children and their families whilst in hospital care by funding projects on innovation over and above that's supplied by the UK's National Health Services. All right, welcome on board. Next up, Arno Valls. Where is Arno? Arno, come on up. So Arno here is the i4Kids Europe Director. He is the Innovation Engineer and Project Manager at the Hospital Sant Juan de Déu. How good was that? Bad, right? Yeah, pretty bad. That's what I thought. Not good with this. Okay, so round of applause for Arno, who's also the jury lead. Next up, we have the only female in the crew, but that's a good thing that we do have one. Arta Barzdiņa, welcome. So Arta here is the head of the clinic of anesthesiology and intensive care at the Children's Clinical University Hospital of Latvia, and is going to represent the Latvian country head. And last but not least, we have Jari Petaja. Jari, welcome. So Jari holds 30+ years of experience in healthcare, including public, private, and also third sector actors. Strong academic background as a researcher and a teacher and a mentor. Published over 60 peer-reviewed original articles, plus a number of reviews and books as well. He is currently holding a position as the CEO of Child and Adolescent Hospital of Latvia, as well as, Helsinki University Hospital, as well as he has the board position in a Children's Hospital of Latvia, as well as member of board and vice president of European Children's Hospital organization called ECHO. Well, that's a lot of roles. How are you juggling all of them? Barely. I can imagine. But okay, once again, round of applause to all the jury members. All right, and with this, we are actually ready to start to hear out what the startups has to say. So just a brief reminder, we're gonna have 6 teams. Each of them will have 5 minutes tops. Better if you don't probably move to these 5 minutes. Everyone wants coffee and also some snacks. And afterwards, I will invite their jury members to host a few questions to each of the team, probably max 3 of them, just depending on how are the startups answering to those, and that's going to be in total for 3 minutes. So 5 minutes pitch tops, and I will do the time framing, and 3 minutes for Q&A. And my colleague there, Kaspars, will help out with handing out the mic to the jury lead. Okay, great. So with this, I'd like to invite on stage, quick pause. I'm also multitasking here. I'd like to invite on stage the first startup, Sensilia. Do we have Sensilia in the room? Where do we have Sensilia? Yes, great. So Amar here is from the Netherlands, and he's responding to the second challenge, and he's going to tell you a bit more about what Sensilia is about, right? Okay, good luck.
Thank you. Yeah, good afternoon. It's really nice to be here, and I'm very happy to. Oh, I think I need the clicker.
Yeah, about that. I'll help you. Here you go.
Thank you. Yeah, I'm really happy to be here, and I'm very excited to introduce you to our project and company Sensilia, where we are developing intravenous infusion monitoring sensor technology to improve patient care. Now, as was briefly mentioned, what we are trying to address is challenge number 2, indeed, which is high-risk medication monitoring in pediatric patients. And one of the ways, or probably the only way in which medication is administered to preterm and critically sick patients in the neonatal and pediatric ICU is via intravenous infusions. But unfortunately, as what happens many times also in medical technology has been discussed already, most of these intravenous infusion systems have been designed for adults. And when you try to extrapolate that to pediatric patients, some not so nice things happen. So pediatric patients especially need a very stable and slow and accurate infusion at all times. Any kinds of fluctuations can really harm them. Any kind of inadvertent over or underdoses can cause neurodevelopmental problems, in extreme cases, even fatalities. And why do these happen? Why do these flow fluctuations happen? There can be many reasons, like occlusions, post-occlusion boluses, which are basically just blockages, just relieving themselves, multi-infusions causing backflows, and so on and so forth. One of the major things that I want you to take away from this is this problem of low flow rates. In pediatric ICUs, we usually carry out these infusions at extremely low flows, with less than 1 ml per hour, which also really increases the risk of problems that can happen, which is basically adverse events. Now, the challenge was posed by the ECHO, but of course, there are many other medtech companies, the FDA, and professional societies that also have talked about this problem and have acknowledged it. Now, what we do at Sensilia, the idea is very simple. We've made a sensor that can perform continuous monitoring of these IV infusions at all times. So the idea is that whenever there is a problem with the IV flow, any kind of fluctuation, we detect it immediately, so in a matter of seconds, and we can alert the nurse as soon as possible. Now, although the idea is simple, a lot of deep tech has gone into making this sensor, and our USPs are basically two main ones. The first one is that we can do this flow measurement in a non-contact, non-invasive fashion, which basically means that we just have to clip on our device onto the IV line, and we can monitor the flow at all times. And the second more important thing is that we can measure flows down to 0.1 ml per hour, which really makes us the first of its kind device, so no such sensor exists today on the market, and we've already filed a patent to protect our IP as well. I want to show you a quick demo about the occlusion detection that I spoke about before. So all of these are just prototypes. We are an early stage company, TRL of 4. What my colleague is doing is he's clamping the IV line so as to block the flow. And you see that on this is our hardware, the sensor, and this is the software. You see that the sensor detected it immediately, so in a matter of 2 seconds. On the contrary, with the infusion pump, which was running at 4 ml per hour, and this is a medical grade pump, it takes about 7.5 minutes. And the 7.5 minutes is basically the time that the drug did not go into the patient. And if it's a high risk medication, such as an inotrope or a vasopressor with a very short half-life, that can be quite critical. We also did preclinical tests on a pig's kidney, a perfused pig kidney, and we infused norepinephrine, which is a very high-risk medication, just to map out what the blood pressure would, how the blood pressure would vary when you have such events happening. So as you can see, the blood pressure starts dropping when you have an occlusion, a blockage, and when we suddenly release the occlusion, you suddenly get this hypertension effect. And when I show this to doctors, especially pediatricians and neonatologists, they are quite shocked because such things are especially what they want to avoid in clinical practice. Now, with our sensor, we realized that we were consistently able to maintain this hemodynamic stability because we measure the event as soon as it happens, not in minutes or hours. And we can maintain this stability and thus reduce the risk of an adverse drug event. A very quick slide to show what kind of traction we've had so far. As I said, we are early stage. But we've already been talking to the market leaders in this space, and we have letters of interest from them to collaborate with them. We are also doing a project with the Erasmus Medical Center. This was actually part of a competition that we won. And we are currently running this project in order to prepare us for clinical trials, which will happen early next year. We've also raised about 1.4 million euros so far. So thankfully, we've been, I would say, quite lucky in getting support from non-dilutive sources, such as the European funds as well as the Dutch government. And we've also raised some dilutive funding when we were incorporated as a company 3 years ago. Now, how we see this pilot project happening if we do get the opportunity is in 2 ways. We are at a stage where we really want to make the next step and really test our solution in patients. So we expect that to happen early next year. And for that, we would really appreciate the opportunity to have clinical validation studies. So really just observational studies.
It's time.
Oh, it's time.
It's time, yes. Thank you, a round of applause.
Okay, thank you.
All right, Jerry, who's first? Here you go.
Thank you very much for the presentation. My question is related to your business model, if you thought on what it would be.
Yeah, so eventually what we want to do is have a sensor which is an active sensor, so something that controls the pump. And so that's kind of our vision in the next 5 to 10 years. And how we do it, there can be a couple of business models. So the one that we are exploring right now is partnerships with the people who make these pumps. So what that means is that we can develop the technology for them, and then they can integrate the sensors into their existing infusion systems, like infusion pumps. And then they take the responsibility of getting CE or FDA approval. And what we do is kind of license our technology to them. So in this way, we can work with multiple people. The other model is to, of course, develop it ourselves. So we have identified certain use cases like really high-risk monitoring where our device can add value as a standalone device. So in that case, we would go to the market alone. And we are kind of in the process of really understanding how much capital do we have to raise to do it ourselves. So that's kind of, those are the two things that we are
Okay. Hi, congrats, because it fits very nice with the challenge number 2. My question is regarding intellectual property. Briefly, how are you planning to protect yourself on these manufacturers not to do it themselves?
Yeah, so our IP basically covers, the core IP covers 2 aspects. One is the fact that how do we make this non-contact measurement, which is the hardware, which is easy to copy. You just have to rip it open. The second is more on the signal processing and especially the machine learning stuff that we do on the device. So that's quite hard to copy. So that's how we want to eventually build our family.
Increasing sensitivity is increasing noise. How do you cope with that?
So what would happen is that even if the flow is fluctuating, let's say you set the flow at 1 ml per hour and there is a slight fluctuation that causes the flow to go down to 0.5, we wouldn't sound an alarm there. So the system would be, would have enough intelligence to know when exactly there is a problem. So let's say when exactly there is an occlusion, or when exactly was there a bolus that was given all of a sudden, or a simpler example would be when exactly there is backflow happening in a vasopressor line. So those are things there where we can see that they would not be very noisy. We can easily make alarms whenever there is a serious problem that's happening without increasing alarm fatigue. I think that's also probably part of your question.
So given the money that you've already raised and the partnerships that you have, what will this award give to you? What do you actually want to get from it?
So right now we are planning to do this project with the Erasmus Medical Center's NICU early next year, but we of course want to do similar studies in as many hospitals as possible, because we also see that when we talk to the bigger players in the market, we see a thing that they are aware of this problem, but they don't want to quite put in the money to actually make it. So what we see is that when we work with hospitals, they see the value in this technology. That's when they can also generate that market pull for these bigger companies. We already see this dynamic happening a bit, and we see that the more hospitals we do this project in, the more pull there will be.
All right, thank you so much. Round of applause. So we are moving forward with the next team, AT Biotech. The team is located in Spain and represented by Aida Agae Marino. So what is AT Biotech then about? They're focusing on monitoring and linking doses and medication to a patient via an RFID wristband. So let's welcome to stage Aida.
Thank you. Hello? Does it sound
Start.
well? Okay. Hello. When I told my son and daughter that I was coming here today, I explained to them that there are many people like them that when they are in hospital, they receive the wrong medication. And when it happens, they suffer stronger consequences because they are more vulnerable than adults and they have a higher risk to have a severe accident. So I explained to them that we had a solution to ensure they receive the right medication in the proper dose at the right time. And they told me, well, Mommy, why didn't you go before? So here I am. I'm Aida Gea. I'm the CEO of AT Biotech. So based on our successful experience in this in dispensing blood, we have in removing errors and improving the overall processes security by using the RFID technology. We have developed a solution. So we follow 6 steps. We identify a patient with an RFID bracelet where we record the medical record number. Then we assist in the process of preparing the medication. So following the electronic recipe step by step, we ensure it is well prepared. We put this medication into a medication recipient with an RFID sensor where we record and identify what is inside. Then we assign this recipient to the kit that has to receive it. And then we are ready to go to the patient. There our system makes a compliance check to verify that we are with the right kit, in the right time, with the proper place, it's not given before, etc., etc. And then we are ready to dispense the medication, and we, with a PDA, we point the bracelet, we point the medication recipient, and if we receive the green light, we go ahead and we can dispense. At the end of this process, all the data collected by our system moves magically to the IT hospital system where it has to be. The medical record, the financial system, the stocks control, etc. So our system is composed by several components. In the center, we have a software that controls the whole process and ensures that every step we give is correct. Then we have the bracelet, the recipient, the location tag, and the PDA, all powered by RFID. And finally, we have to integrate the IT systems. So using all those robust technologies, what we have is a system that has many advantages, but the most important thing is that we are able to detect and prevent up to 100% of errors in dispensing. Additionally, we can focus on the kit and reduce administrative burden and collect data for a later inspection. So, what do we need to make well, what we want to show you is that with a simple pilot, we can obtain all those benefits that are not only possible, but affordable. So, we suggest we select a highly critical medication, we engage in a 1-month pilot, we set the right KPIs, and check. We don't need believers. What we need is to get convinced by the evidence. So, what do we need to make a pilot?
1 minute left.
We need to involve doctors and medical staff. We need to verify and validate the protocols and processes. We need to integrate systems, deliver the hardware, the software, and finally train users, go live, check, and validate that the system is working. HE Biotech is a small company based in Spain. We work in traceability since 2013. And what we are proposing? We are proposing to be the challenge. We propose to reduce the dispensation errors to less than 5% and to reduce the administration burden and the paper consumption by 15% in a pilot project of just 1 month. Thank you very much.
Great. Thank you. Amazing timing. They're jury members. Questions? Who's starting?
So, if I understood correctly, well, first, congratulations for the project and the presentation. If I understood correctly, you take the data from the hospital to your systems, and then the outcomes of the calculations of your algorithms come back to the system. I would like to know a little bit more how it works and how compliant it is also with the GDPR and the data that should be at least to the hospital, staying in the hospitals.
Well, all data belong to the hospital. The sensors are integrated into the hospital system, so it's not going outside the hospital. So we simply put sensors to identify what is happening at every time and recording all the important data related to the process. Then the systems are integrated, and the system that is collecting is our system, but then the data finally go to the system in the hospital that has to store it and use it. So there's no GDPR concern.
I have no doubt that your children are right, that this is, if you can implement this, it will be extremely good technology. But have you looked at your competition? Who else is out there trying to do this? Because RFID technology has been around for a long time. Just wondering who else, or if you've discovered anyone else that's doing something similar.
Yes, this is a good point because it seems very simple, but there is no technology that, at this time, even in pediatrics or for adults, that is taking care of the final mile of dispensing the medication. So this is something that we are missing. Normally, at this stage, what we have is data from nurses that are dispensing the medication, but they are too busy sometimes to collect all data. So this is a way to have all the records complete and ensure what is happening really in the field when we are dispensing the medication to the patients.
Thank you for your presentation. I would like to ask, different hospitals have a different system. And how is your system very friendly with all those systems?
Well, we have in the legislation, we have several formats that are compliant one with each other. In the hospital, we are used to have many systems, many IT systems. We have standards to integrate the different systems, and they are working because we have lots of different suppliers in the hospitals. So we are just one more.
Thank you so much, Aida. Well done. So we're continuing with the third team called Speaknosis, quite international team, representing a team from Chile, the US, and Spain, and here today represented by Cristobal Longon. Cristobal, please welcome on stage.
Thank you. Good evening, everybody.
Round of applause!
So you see what happened here? There is no connection, no bonding. This is what happened in every medical consultation. This leads us to that the doctor is always taking notes, trying to do administrative work, and not be with the patient, bonding with the patient. Two problems. We want to improve bonding with the patient. This will make, our solution will make that all the ambient data from the consultation will be recorded and put it in each side. With that, we will reduce burnout of the doctors. You see, half of the doctor has burnout. That's incredible. You have a happy patient, happy doctor. You will have for healthcare manager, happy data, and you can do your job. You will do your job and all these statistics. So what we are an ambient solution. We take out all the interaction nowadays between regarding voice between the doctor and its patients, and then we process it with our own made algorithm and based on LLMs or AI, so-called, and we created this Speaknosis PET specifically for pediatric patient. Pediatric patient, I'm an ENT pediatric surgeon. I really want to talk to the kids. We really need that the AI really understand how the kids speaks and express and differentiate from what the parent says. So we create an algorithm that can understand this and then create and integrate all this data. We already tested in our department, ENT department in San Juan de Diego Hospital, and in a tier 1 clinic, I cannot say the name, sorry, in Latin America, specifically in Chile. Because we are in Latin America, we support multilingual and most important, regional dialects. We speak Spanish in Latin America, but Argentinians, Uruguayan, Paraguayans speak differently and use different kind of words. So we are able to detect and process all this kind of data. And also, we don't storage any data. So this is how we integrate with your EHR. We have these 3 different models, but we really like the middle one. I will show you why, because the providers will not have to invest a lot in the integration. So we propose this kind of integration for your hospital. So you have your electronic health record. We have our pop-up Spignosis. We have all our engine behind. We believe in doctor-AI interaction. We don't want to replace doctors. We want that the doctor validate the data. Only once the data is validated, we will process it and structure it to the electronic health record or wherever you want the data goes. So we can then, because of the ambient data, code all the data, the diagnosis, the symptoms, or the procedures, and then we will return it to your electronic health record. Even more, we can create any additional document you want or you need. Okay, one of the that we is really working really good is patient summaries. We send a summary in human language to the patient, explaining not in medical language, in human language, what they have and what is their disease about. This is our team. We are 4 founders. We have a nurse, techpreneur, myself, Felipe is an AI expert, ex-Google, and Sebastian Miranda, ex-insurance company CEO and data analyst. And we have all this kind of, and the developer team, Eduardo Rosales, ex-Google also. I have Diego Brown, is software development and also a linguist. Sorry. And then we have Francisco Veganigo, is the business engineer and B2B expert in Latin America. Sorry. So we already have been validating this.
30 seconds left.
In Spain, we have won these prizes, and we have this active integration, and we want you to use our system to really land here in Europe and help you process the data. Thank you.
Great. So who's first?
Hi, congratulations. Can you elaborate a bit on who is your client, how you want to reach this client,
exactly.
especially in Europe?
Yeah, we have actually noticed we have 2 business models. One's B2B, health providers, big hospitals, big private clinics. And now we are working really on B2C because of I don't know who said it, because we have to come from below, attacking the doctors, specifically in Latin America where they have big private practice, so we want to reach them as well.
How far have you got with your EHR integration? So is it ready to go? Is it an open API?
Yes.
With and who have you tested it with?
Sorry?
Who have you tested it with? Which
those clinics.
Which EHR systems?
Sorry. We have been tested, all the clinics we have integrated, they have their own EHRs. So exactly.
Continuing, so no Epic?
No.
Maybe the last one. Congratulations for the presentation. How is it the competitive landscape?
Really tough, but you see, when there's a lot of companies fighting, because there is business there, so we are really happy about that. Regarding Epic, maybe because of our marketing strategy, if you go to Epic, it's more difficult. You go beside, you have more market share. Yeah, exactly. Yeah, no. Yeah, we develop everything starting from Chile because children's, because I work in San Juan de Deu, but we have also for adults as well.
There's still time for additional question if you have some. Okay, I think we're done here. Thank you so much. Great, so we're continuing with the team number 4 called FIBO. So FIBO here is from Brazil, represented by their founder, Alvaro Moreira. And they're working on multi-language tool that predicts possible no-shows. So here to explain more. Round of applause.
Thank you, good afternoon. Very happy to be here. I'm Alvaro, I'm founder and CEO of FIBO. And we are committed to a clear purpose, which is to optimize hospital operations and reduce waste. Every year in Europe, millions of no-shows occur, generating delays, stress, inefficiencies that cost millions of dollars, of euros, and of course, probably some thousands of lives. Our AI-driven solution, it balances supply and demand, taking into account the hospital's scarce resources, the operational constraints, restrictions, and of course, dynamic objectives such as medical teams, resource usage, and of course, patient care. We predict, the system predicts the no-shows by using historical data. So what it does is when an appointment comes in, the system predicts the probability of a no-show, suggesting strategic overbooking, okay? But at the same time, it reminds family of their appointments, allows for pre-check-ins, and not less important, in some cases, the filling of pre-appointment health monitoring checklists that might indicate the likelihood of a children missing an appointment. And one of the biggest factors behind no-shows are the highly complex multi-appointment schedules. And the system, it coordinates the different specialties, the machines, facilities, and of course families' availability in order to make sure that in one single visit all the appointments occur and with a minimum lead time in between events. But at the same time, we want to allow for other objectives, for example, continuous care by a specific physician, and allow for a long-term planning. That's very important because it increases and enhances the predictability of the process. In oncology, we minimize the waste of chemotherapeutic, highly perishable and expensive chemotherapeutic doses. And we do that by optimizing the chemotherapeutic schedule, balancing the patient needs, balancing the availability of the facilities, and of course the drug's life, reducing both financial and medical waste. But we know that no matter how optimal an agenda is, there will always be no-shows. And in case of a no-show, we want to make sure, a critical one of course, we want to make sure that action is engaged immediately or as fast as possible to make sure that the minimum impact is generated in the children's health. And with so many stakeholders involved, and different stakeholders, we know that communication is paramount to the success of the processes and all. So we support an omnichannel solution that even allows for users to select their language, which is something in some cases very critical, important, because we know of the migrant influx in Europe, and some people really have a harsh time communicating themselves and understanding the language. In terms of implementation, we are very flexible. Basically, we can run a pilot to validate.
1 minute left.
To validate the database, and to validate the database, and to customize our AI engine. Or, of course, we can go towards fully integration and deployment of the solution. We have implemented our various solutions in over 15 hospitals all around Brazil, which is quite challenging considering the continental size of the country. And we serve clients as far as from Riga to Lisbon, so it's not that easy. And also we started a company from scratch in one of the poorest regions in Brazil. We have an experienced and mature team with solid knowledge in AI, hospital management, Lean and Six Sigma, and by choosing us, you'll be not only choosing an advanced technology, but also a purpose-driven one that will surely save some lives and some millions of euros. Thank you.
Thank you.
Okay, congratulations for the work done and the implementations. As you are mainly now based in Brazil, I take a question that was made also before. With which systems, EHR systems, do you integrate?
We integrate currently with Brazilian ones, of course, but not being falsely modest, our IT team has got a lot of expertise in integrations, and we deal with different integrations in Brazil, which is not that easy also, and that's one of the reasons why we applied to this contest. We are looking forward to come to Europe and be able to integrate with European, of course, systems.
Okay, congratulations.
Thank you.
I think how you've been implemented that in Brazil, I think it's really an achievement. Why this is relevant? Can you explain a bit why this is going to impact precisely children's hospitals?
Okay, well, not only but also, first and foremost, when you look at children specifically, ones that have chronic diseases or complex one, normally they have very long treatments, and it's a burden for the families emotionally and financially, but also to get all the involved together and making things happen, it's quite complicated. And the fact that our AI engine manages to create the best optimal agenda, considering an heuristic approach in terms of AI, okay, the benefits are quite amazing, in terms of using of the facilities, using of the personnel, granting that you can have a continuous care by a specific physician, and that when you move from one city to other, that many people have to do that, you have access to all the appointments and you don't have to come back and forth. I think that's quite important.
So I'm sure you can't give us all the data, but what are some of the data points that you're looking for in order to train the algorithm to try and give you the indication as to whether or not a child is going to attend an appointment or not?
Well, the spectrum is quite broad, and actually in terms of no-show, we are testing with one hospital that is our client already in other solutions, and with a small imaging clinic, because they have very different processes of inputting and maturity of inputting the information. But it can be as broad as the day of the week, what time it is. You can have with which advance the consultation or exam or the multi-appointments was generated, the demographics, where it's coming from, if the family has got own car, or if they use public transportations. So that's also work that needs to be done, which is to not create, but to frame a better database input, that's critical, of course, because different hospitals have got different, and that's also, to be honest, that's one of the challenges, is to understand the quality of the process of inputting data. Because if you have false data, AI won't work. So that's also very important.
Thank you. Round of applause. So we're moving forward with our fifth team, Tortoise.ai, another AI-driven platform here, represented by their teammate Jasmine, or Yasmin, Balok.
Thank you. And
Great.
my colleague Hafsa. Could we borrow the second mic, if that's okay?
Sure.
Thank you. Sorry, we're going to do a live demo. So there's two of us, but no time for live demo. But lovely to meet everyone. I'm Jasmine, Chief of Staff.
I'm Hafsa, I'm the Product Manager. Thank you. And we are going to talk to you about Tortoise. So I'm just going to stand next to you, Jazz. So the problem that we're tackling is the improving the clinician workflow, focusing on admin on the documentation side. So our tool is a desktop app, but it also comes in various versions and can integrate with your EHR. It listens and transcribes to your consultations. It generates structured notes, letters, and coding, so it can be filed directly into your EHR. There's instant intelligent dictation as well, so for other tasks outside of that workflow, it can assist there. And we also have workflow automation, so admin tasks that go outside of the scribe and note-taking realm, and that's kind of coming soon, but we work with our partners to develop that element. So we have a demo here. So you will start the consultation, you will say hello to your patient, see what their problem is, you'll wrap up that consultation and press finish. The transcription will load instantly, we're always surprised by this. And then you can have a look through to make sure the audio has worked and it's captured everything. But that summary will be generated super quickly. And it will provide the information in a really structured manner that mimics your style and can then be pasted into your EHR. You can also then generate a letter, and there's different types of letters that you can create bespoke, and also different coding systems to choose from that match with the system in your hospital. You can also choose a different style, so you can customize that note. And it will all generate quite quickly. We really keep the patient in mind, so we have kind of notes to the patient in the UK. All EHR records are accessible to the patient, so we bear that in mind and kind of what the note says. And it will generate that structured output in a really seamless manner, so you can really spend that time focusing on your patient, maintaining eye contact, and increasing direct care while reducing your cognitive load. So the benefits of this are, again, listening to your patients, maintaining eye contact, and really increasing that direct care, which is so important, especially in pediatrics. Improve the quality of the documentation itself. Like I said, patients get access to that. Save time. It's interoperable with any EHR. It's a layer that sits above, so it doesn't really matter what your system is. It's secure and compliant. We don't store any data. That's really key. Having patient trust is a core part of our business. And we just have a commitment to innovation, so we can work with, with different hospitals to leverage AI to make it useful. Over to Jasmine.
Great, thank you. Already got one. Thank you so much, Hafsa. So we have a research partnership with Great Ormond Street, meaning everything we've done to date has been tested in a phased approach, similar to, say, a clinical trial approach, in-house at GOSH. And with GOSH now, we're moving into a London-wide study. So we're UK-based and have done everything to date we have clinically evaluated in English language. However, we would like to expand this into a European language now. However, we need to clinically evaluate this. And this is what we'd like to do with a pediatric partner in Europe. So in terms of a pilot, we would design a protocol, and this includes a time and motion study, so recording exactly what a clinician is doing in clinic, minute by minute. We then experiential survey both the patients, the parents, and the children. So we want to get everyone's viewpoints on the technology and how effective it was in that setting. During this pilot phase, we train clinicians thoroughly on the use of the technology. We give them a familiarization period of about 2 weeks so that they can learn how to practice with the new technology and adapt to it, rather than just putting them straight into a room with it. We collect both baseline and intervention data and then compare these directly with the time and motion, and the experience data. And so we recommend doing this in more than 5 departments across outpatients to see the impact then on the admin burden time-wise. Thank you so much. So to date, as I said, we've done this at GOSH. We've also just finished at Kingston Hospital in the UK, where this was also used in the pediatric department. So 25% more direct care with 1 in 4 clinicians, decreased consultation time by around 7 minutes for top users. More clinicians completed their notes in clinic, so 20% more completed in clinic, and 82% said their clinic was better with Tortoise. And so just to finish, we have a world-class team. We're led by an NHS cardiologist. He's our CEO. We have a team of about 20 now, a mix of engineers, clinicians, and a business development team. Thank you.
Thank you, ladies. Over to Jerry.
Interested in small languages like Finnish?
I'm Latvian too.
Yes, definitely. We use a transcription model that can transcribe up to 100 languages. We just haven't done that clinical evaluation piece, which is where we need clinicians who speak that language. And so we obviously, being based in the UK, have a high cohort of English-speaking clinicians. But if we were to pilot in Latvia or Finland, we could essentially utilize the resource of clinicians in that country to clinically evaluate our models in that language.
If I understood correctly, you are working for different specialties, cardiologist, pediatrician, gastroenterologist, and so on, yeah? For surgery, for operating theater?
Yes.
Oh, okay.
Yeah, we can do operation notes as well, so we've done that before.
A bit tricky question. Since you are already a backup company by VCs and investors, and congratulations on that, why you see value on this program, why you are looking for this award? Thank you.
Yeah, I'll hand it. But from my angle, it's definitely the resourcing. Like, as I said, I lead the research work we do in the UK with Great Ormond Street, but we don't have that language capability.
Yeah, exactly that. I think the European market is so varied. There's different languages within the market. It's not like, UK where it's all one. So it's actually just leveraging that local knowledge, awareness of the health system within that region, as well as that language clinical support as well.
Thank you.
And how do you envision a payment model of that?
A payment model, did you say? Yeah, so we have typically a licensing approach. So per hospital, but there'll be a license for the annual fee, for example, and that will include a certain amount of usage based off the size and the types of clinics. And then if you go beyond that, there'll be some sort of per hour model. But again, very flexible and here to adapt to the needs of the hospital. Each hospital is unique. So it's loose.
So independently from the amount of users?
Yeah, exactly.
All right, thank you. So guys, we have arrived at the very last pitch of today. It's the sixth team presented by Mariana Liano. She's from Portugal, working on a startup called EniexCare. And in EniexCare, they focus on building a multi-language tool for appointment efficiency, enhancing patient experience, as well as reducing no-shows. So a round of applause for our last team here.
So,
Okay, we're done today. Thank you.
I hope you are not too tired for this last presentation.
Never.
Well,
never for you.
My name is Marian Liaño. Actually, I'm from Spain, but I live in Portugal. Thank you so much for having us today here. Sorry, this is not working. Please stop the time.
Sure. Yeah, I shall. Don't worry about it. It vibrated for a second, but it doesn't seem to be working after that.
Yeah.
Can we get help from the...
Yeah, the tech team is working on it. Don't worry.
Oh, okay.
Yeah?
Okay.
Okay, great.
Okay, and I'll
Let's continue.
Thank you very much. So let's start with this number. Did you know that 20% of patients fail to attend the appointment every day? That means 20% less space utilization, human resources, and of course, increasing waiting list. We know that if it's a call center, if it's the staff from the clinic that calls and communicates with patients, the no-show decreases. But this is too expensive to do. However, it's the ideal opportunity for artificial intelligence to intervene. So, because it will be able to do the work with almost the same knowledge as the hospital staff, but it will be doing it faster and with better result. With that information, 8 years ago, ENIAX created a system based on an AI engine with natural language processing called Patricia. And based in the real needs of health institutions to make administrative tasks more efficient. Our virtual assistant, Patricia, has a brain made with machine learning, the ability to communicate thanks to the natural language processing, but she also always has a team, a great team behind her that help her to understand when she cannot understand, answer. So she's constantly training and learning.
This is Patricia. The communication, we start from the beginning in the scheduling moment, and we communicate through all the digital channel. And we guarantee, because of ability to communicate with her, guarantee an effective communication with patients during the whole patient journey. Why we are different from our competitors, chatbots or call centers? Because we focus on understanding our patients' needs and making reliable and meaningful connection. It's all about the communication. When we can communicate properly, we have all the information the patient requires. So this is where we get to the data. We have 230 million schedule experience. And because of that, Patricia doesn't not only recognize appropriate words, but the context in, so the meaning in the sentences. That's why our clients, since the first month, since the beginning of the implementation of our solution or our system, has reduced no-show in 50%, with 90–70% of success, of satisfaction in the services we deliver. And this is very important. Because of our extensive data, we have 95% of accuracy in predicting which patients are more likely not to attend. So we can offer those slots to other patients that are on the waiting list. We are a global brand with presence in 7 countries. We have offices in Spain, Chile, Argentina, and Portugal. And actually, Patricia has been implemented in 350. We are working with the most largest group. And Patricia is actually speaking Spanish, Portuguese, and Catalan, but she's also fluent in English, French, and German, and we are hoping to deliver our services in more hospitals and clinics in Europe, hopefully very soon. That's why we are here today. Just to conclude, the no-show and waiting lists are a big problem, and that's where we can work, so we can give access to medicine and to medical care to the patients, and that's what we do in ENIACS. We focus on generating better connections between provider and patient to make a better care delivery.
Thank you. So a very important question from my side. Is Patricia's avatar based on your looks?
No. Actually, she can be customized, and she can be called with another name or...
She looks great. She looks great. Okay, let's move to the jury's more important questions probably. Who's first?
Hi, thank you so much. Have you done this in a pediatric setting?
Yes, actually, one of our clients in Chile, it's Teleton. We started with a pilot program in 2021, just with some appointment notification. And after 1 year, we were working and integrated with its 14 centers around Chile. And actually, it was a great benefit for children, because in Chile, for example, they have to travel from very remote areas, and many times they have several appointments, so communication with them was a very big problem, and having the possibility to have all the information, being connected so they could ask and answer questions has made for them a much better experience. Actually, in the previous panel, they were talking about that. It's all about the experience of the patient, and in our case, it's all about the communication. If you communicate in the right way, you make everything else happen. You build the patient loyalty, you can offer much better care, and of course, you increase the operational results also for the clinic.
So being backed up by a Bupa and those big multinational companies, what do you expect from the prize and the pitch and the network of i4Kids?
Well, as you have mentioned before too, Europe, we are different countries, and we need to access to the countries. Right now we are in Spain and in Portugal, but our hope is to get in the rest of Europe. Obviously, considering there are different languages, but I don't know if I've been able to explain it because, sorry, I got super nervous and my pitch was a bit disaster. So the idea is that we want to enter in new countries with new languages to be able to deliver the results we are already finding in our clients, reducing absenteeism no-show by 50%, which is amazing.
That's time. Okay. All right. Thank you so much. Yeah, let's have a round of applause for all the 6 teams once again. And sorry to teams if you got like a bit more stressed when I said that the time is almost off. It's part of your lifestyle, guys, if you're pitching to hospitals. Anyways, we're now ready to start the evaluation process. So the jury will leave the room now for about 10 minutes and get in one cozy room to decide on the winner. And once they come back in 10 minutes, we still want you guys here, right? For the... Okay. But that's gonna be like a tough one to get them back in, but sure. Okay, guys, go for a pause and let's be back here in 10 minutes.
Hello, everyone. I feel like everyone is prepared to have the wine that we are going to have, according to the timeline, in 2 minutes. We're going to take like 5, maybe 10 before that. I am very, very, very sorry for this inconvenience. But we have to recognize a winner. And we just had the challenge, and we heard 6 pitches. The jury deliberated very seriously. You should have seen the image of these 5 people, like super intelligent, like just murmuring in these ideas, flying around, and the photographer complaining that they have decided to be in the darkest corner of the room, and the photographs could have been more epic, but still, nonetheless, the deliberation is complete. And I just want to rehash that the stakes are kind of high. There is a 5,000 euro grant to start a pilot project in one of the i4Kids Europe hospitals, and a voucher for consultancy services with the Invenium group, to whom we owe a huge thank you. And that is that. And to actually announce who the winner is and slightly, briefly describe what the process was and what the decision-making, how it went, I will invite one of the jury members, and it is going to be Arta Barzdiņa.
Hello, everybody. These were very hard 10 minutes for jury today to choosing, but the process was very friendly. And yeah, we should remember why we are there today. And we are for innovations to help children. My heart went out for everybody, of you presenters, of everyone, but I haven't 30,000 euros, just 5, for one of them. For you, and my decision and jury decision, we think the grant, 5,000 euro, goes to Sensilia. Super. Congrats. And why? You know why? All of projects were excellent, and I like them very well. But you know, this project is 100% for neonatology patients, and I am working in intensive care. I know how hard it is. And you know why this project? Because the pilot is, I think, practically ready to start. That's why your program, your device, and I think it will be real things to help neonates.
And last but not least, there is this certain innovation engineer and project manager at Hospital Sant Joan de Déu. And I think what solidifies him as being the person to say the closing remarks is that he is the i4Kids Europe director, Arnaud Valls.
Thank you. Well, thank you all. What an amazing day have been. I think that from the moment we started, we could feel this good energy that some of you also mentioned during your presentations, the vibes, and a lot of food for thought. And I think that's why we started all this. So we are a big community coming from different backgrounds, from different companies, from different countries also, but all with the same goal of changing and reshaping the future of pediatrics care. And I think we've seen here today this energy and how it is needed. So before continuing with some of the remarks of the day, I would like to give a special thanks to our host, to the Children's Hospital of Latvia, for hosting so well these days here, for showing us how is this ecosystem growing and how amazing things are going in your hospital. I would like to thank especially Elina Datse for the amazing work you've done organizing the whole day, but all the team, and I don't want to lose any of you. Ilona also, also Yeva, Elina, Arta, Marta, Patricia, Sofia, and Luis from the i4Kids team. So before continuing, I would like to ask you for a big round of applause for all of them, because it would be impossible without them. Also, I would like to give an applause to the one that have been asking for that the whole day. So our moderator, amazing work he's done. So today's them have been advancing the frontiers of innovation for a healthier future for pediatric care. It's been brought to life since we started and in each session, whether it was through the innovation and adoption challenges and barriers that we've been working through the working groups for the whole year, or with the fascinating discussions and examples of how AI is implemented, also innovations using biodesign, lots of learnings also on how to implement innovation, not only in new products, but also in the building and how can reshape the whole process of healthcare service delivery. But also discovering amazing projects like Batcaves. I think we all now want to have a Batcave in our hospital. We started having a privilege to hearing Charlotte present the challenges and opportunity roadmap and the white paper, and how the roadmap abroad is challenging, but also full of opportunities. This white paper is the culmination of a year of work of all the i4Kids Europe network. And it is reflecting the collaboration efforts of all the stakeholders. So not only us, but also a lot of people that from the European Medical Agency, the European Commission, and lots of industry partners have collaborated to make it happen and gather all this data. This will be published with the final and more than information. Now we have 54 pages that we have to sum up. So big work ahead, but we hope to have it published by the end of November. So we invite you all, if you are interested to know more data on that, to check our social networks that will be informed. So we've identified both the hurdles we must overcome and the tremendous opportunities that we have ahead. From regulatory frameworks to funding mechanisms, it's clear that fostering innovation requires coordinated pan-European effort. We highlighted how we can accelerate innovation, in fact, while ensuring that these breakthroughs reach the ones that really need it, our children, but that this needs to be done together. And an example of that is here today. One of the most exciting parts, at least for me, of the day, which it's been the Hospital Challenge, big finale, where we witnessed the incredible pitches from startups and companies tackling real unmet needs from clinical operational needs. And I think this and the process that we did on that is an example of how things can be done. So we gathered the CEOs, and thanks to all of them also, and to Riga for also helping on all this coordination to select and prioritize the three most important challenges that we all face. And I think that's a reality. All hospitals around Europe at the end, we face similar challenges. So that's why we decided to create this, a call for solutions to benefit all of us and inform, as it was said in the fire chat today, inform those innovators and startups that have the solutions and the energy to find solutions for our childs. But the road ahead, as we said, is exciting and demanding. The challenges we face in pediatric healthcare require that we continue collaborating across borders, disciplines, and generations. Together, we have the power to reshape pediatric healthcare and make the impossible possible. So, as we live here today, I think I would like that all of we can carry this momentum forward, the connections that we've done cross borders, so that turning today's ideas into tomorrow breakthroughs. The future of healthier generations, at the end, it's in our lives. Here we have all the ecosystem. So let's make it happen. Thank you all for coming today here in Riga. And we would like also to announce that we hope for next years to have the Pediatric Innovation Day again at the same, more or less, at the same dates. And it will be in Barcelona probably. So we invite you all to Barcelona to come on the next day. And please, all those connections that you've done these days, don't make them die. Let's continue with this momentum. Let's connect and reconnect for a better future of pediatric care. Thank you.
Nice. So last but not least, thanks to Igloo, thanks to Invenio, who gave the money, thanks to you, and it's almost 4. It's like I'm literally stalling for like 16 more seconds, but the plan now is to go get some wines, get some visit cards, boost your LinkedIn whatevers, make decisions, make partnerships, and did I already mention the wine? Thank you.